Yes, once again, good afternoon, everyone. We are resuming our sessions post-lunch. I would like to invite the chairpersons, Dr. Sulfikar Ahmad, Dr. Suresh Kumar R., Dr. Krishnamurthy K.M., Dr. Deepa S. Kumar onto the dais, please. Our first topic is about PFO closure, current indications and how to do. And our speaker for this is Dr. Praveen Srikumar.
Good afternoon. First of all, thanks Vinod for making me a part of this meeting. And this regarding PFO closure, current indications. PFO is a very common incidental finding on echo in most of the cases.
Is the audio working? Meanwhile, we can invite Dr. Srikumar in retrospect. It's already started. It's a great topic that he's dealing with. The indication for PFO closure and the technique of it and the do's and don'ts associated with this are things that we would like to learn from you. Dr. Srikumar.
So I think I'll come to, because PFO is a very common incidental finding on echo. In fact, 35% of people will have PFO if you take a routine echo. And the PFO is basically occurs when septum primum and septum secundum fails to fuse after birth. 1/4 of adults have this defect. The often quoted incidence is 25%. And it's a usual incidental finding with no clinical repercussions. So when do we clinically want to close a PFO, or why should we close it? So it has been associated with a range of clinical conditions like cryptogenic stroke mostly, and migraine, platypnea orthodeoxia syndrome, and decompression illness. These are the 4 common associated syndromes associated with a PFO and clinically significant ones. First PFO associated stroke was described way back in 1877 by Cohnheim, and this was the first successful PFO device closure was done in 1992. So first paper in AHA. And cryptogenic stroke accounts for about 40% of all ischemic stroke. There has been heated debate about role of percutaneous closure of PFO in patients with cryptogenic stroke. And 3 randomized studies came up in the early 2011-2012. First result came in 2012, the closure 1 trial. Then RESPECT and PC trial also was published in 2013. But these trials gave a negative result, non-significant difference between closure and non-closure closure of a PFO when compared to antiplatelets and anticoagulants. So there was an initial inhibition, but actually the event rates were very low in the first 7 years. To get at 25 events, to analyze for the result, they took 7 years to get 25 events. So after that, the Kaplan-Meier survival rates of events started diverging. So by about 2018 and 19, further trials by that time came available which showed clear benefit. I'll come to that. And even RESPECT sub-analysis showed that there is late benefit of closing a PFO in certain subgroup of patients with cryptogenic stroke. And some of the risk factors associated with paradoxic embolism are: 1, large size PFO more than 5 millimeter is significant. Persistent right to left shunt at rest. Suppose you do a bubble contrast echo. If the bubble contrast more than 20 bubble is what is, they say that significant right to left shunt enough to close a PFO. Then atrial septal aneurysm, which means more than 10 millimeter excursion from the plane of the atrial septum. If that is there, that is associated with a higher risk of cryptogenic stroke. Then presence of a prominent eustachian valve, that is also associated with a higher risk of cryptogenic stroke in patients with PFO. So these are the common higher risk associations which can cause cryptogenic stroke and would be a indication to consider closing a PFO. This is a saline contrast echo. Saline is injected, either saline or you can use a contrast agent like Definity. And when injected into the right atrium, within 3 cardiac cycles, if it comes to the left atrium, there is some shunt. So that will be the diagnostic one. And there has been a ROPE scoring system. It's a clinical scoring system. And based on this, suppose the score is above 7, then they also fall into high risk category based on a clinical assessment. Of course, there are other echo factors which I had mentioned before. And basically, suppose 0 to 3 estimates 0% probability of pathogenic PFO and 20% probability of a recurrent event. This is done after the first cryptogenic stroke. So it's a risk stratification, secondary risk stratification scoring system. So suppose it is more than 7, then for a cryptogenic stroke, you need to consider PFO. And so for current indications, these will be the main categories. One is patients who had a cryptogenic stroke. Even with patients without cryptogenic stroke, suppose they have migraine. I'll come to the current recommendations, SKY recommendations later, but these are the considerations. Then platypnea, orthopnea syndrome, decompression illness, and proved or suspected coronary artery embolism. For example, recurrent MI in a patient, repeatedly coronary arteries are normal. In such patients, if there is a echo finding of PFO, whether to close it. So these are considerations. As of 2018, 2 US FDA approved devices are there. One is the Amplatzer device, the Talisman device, and the Gore cardioform device. So these are the 2 US FDA approved devices as of now. And the procedure of closure of PFO is not very difficult. First, we need to wire with a multi-purpose or a JR catheter. We need to probe the septum, interatrial septum. If there is an aneurysm, sometimes this might be difficult. Whether we have crossed the septum, we might not know. So that is confirmed by crossing to the pulmonary vein. Or once you need the thermo to go to one of the pulmonary vein, confirm with either LAO or RAO view that it's pulmonary vein, and then once it is in pulmonary vein, park it as distally as possible and push the multipurpose or the JR catheter into the pulmonary vein. And once it is in pulmonary vein, we can exchange with a stiffer wire like Amplatz wire. And mostly the problem will be with difficulty in wiring. Unlike an ASD, it may not cross very freely. So we may have to slightly push it. If there is a transesophageal or a ICE guidance, that is best. We can direct it towards the septum. And once the delivery sheath can be put over the Amplatz wire, then it is just like an ASD procedure. We can pull back from the pulmonary vein the delivery sheath and deploy the left disc of the device on the left side. And by echo or transesophageal echo, we need to confirm that the left disc is completely inside the left atrium so that it is safe. Otherwise, it may catch one of the lip and come back. So because there might be atrial septal aneurysm, it might be loose. So this need to be confirmed by a on-table echo or before deploying the right disc. Then you can slightly pull on the whole system, delivery system, and then by pulling the system, you can deploy the right device, right end of the disc. And this also can be confirmed by ICE or transesophageal echo. And once it is deployed, an angio is taken to see whether there is any device leak. Peri-device leak is one of the highest risk factor for recurrent thromboembolic events even after PFO closure devices, and that was even more with the previous Starflex device, and it was used in trials also. The earlier trials used Starflex devices. Nowadays with Amplatzer trials, there are better results with less of late device embolism and device thrombosis. So now devices are better these days, and this is an angio done at the end which shows that. So earlier trials were negative trials, but later trials like Reduce, Close and Defense Pro trials showed that there is less incidence of recurrent stroke events following PFO closure. So patients who would benefit with a PFO device closure would be young patients with recurrent cryptogenic stroke. Young patients with recurrent MI with normal coronaries needs to be considered. Associated recurrent DVT, atrial septal aneurysms, right to left shunt, more than 20 bubbles if on contrast echo, presence of a eustachian valve. And migraine, about 47 to 48% of patients with migraine have associated PFO when compared to 17 to 20% general population. And some trials like PRIMA premium trials showed that there is a benefit in reduction in migraine headache after PFO closure. This is not for the stroke. And platypnea, almost 100 patients of cases will improve after a PFO closure. So that will not occur after a PFO closure. So by SKY recommendations, if there is a platypnea orthotia deoxia syndrome, by itself is an indication for PFO closure if present. And decompression illness also, there are no randomized trials in this group of patients. It's a rare subset. So this is SKY latest recommendations. In that, as a primary prevention, suppose they don't have a cryptogenic stroke, only two indications are there for closure, either platypnea or orthopnea syndrome, where PFO closure is recommended, systemic embolism, approved systemic or cerebral or coronary embolism. Only these two are present recommendation. A simple TIA, DVT, septal aneurysm or any thrombophilic state with PFO and migraine is not actually a recommendation for primary prevention for a cryptogenic stroke. Suppose they have a cryptogenic stroke, then the situation is different. Then 18 to 60 years, PFO closure is now preferred over antiplatelet therapy. So this is a widened indication. This is a SKY 2022 guideline. And above 60 years, it may be beneficial in high-risk cases with high-risk features which I mentioned earlier. Then AF with cryptogenic stroke is still not recommended. And thrombophilic states also, it is recommended to do a PFO closure if present, along with lifelong anticoagulation. So conclusion is, it's a highly prevalent condition in adults. Studies trend favor PFO device closure for cryptogenic stroke in selected group of patients with high-risk features. It is justified in recurrent stroke, young MIs, associated DVT and high-risk anatomic features. Thank you.
Thank you, Praveen. I think it has been a wonderful talk. I just want to have one question. Basically, in spite of volumes being written on PFO, many of us young and old have some doubt regarding what exactly is a PFO. Yeah. So the definition of PFO, how does it differ from the regular ASD?
I think one is PFO is usually it has a tortuous course. It's usually it produces a right-left shunt, and in a ASD it's a true defect. The edges will be a true defect. On TE you can see a true defect on the edges. Other is a separation. PFO is just a separation. So that should be the closest definition. Anything?
A couple of comments. Dr. Praveen?
It's a defect in the failure of primum and secundum to fuse. That is what is given as definition.
We have all been...
Some people define as a right...
Arun, Edwin, yes.
As a absolute right-left shunting as a PFO, because there is no clear definition probably. They say that some people say that it has to be a right-left shunting because of the valve mechanism, unlike an ASD, which has to be a left-right shunt.
Taragan sir insists that if there is a resting left-right shunt, it is not PFO. It has to be ASD only. So, resting left-right shunt is not a PFO.
So maybe
provocative is different. And a couple of comments. Migraine is not recommended, but migraine, there is a compassionate ground for closure if there is aura. If there is a compassionate ground.
Still guidelines, they have lack of evidence.
It's only compassionate.
That is why in that subset of population.
Just two more points. This cryptogenic stroke, we have been harping on cryptogenic. But when there is a PFO with a cryptogenic stroke, it is no more cryptogenic. It is PFO causing stroke. It is not a cryptogenic. Cryptogenic, there is no etiology, neurologically.
And that too, cryptogenic, we have to ardently search for other causes of stroke, including ideally an MR angiogram to show that it is the cerebral vessels are entirely okay. Only then...
there need not be other evidence of right-left shunt. PFO is there, and suppose there is a history of a young man who has travelled for 12 hours, and there is a stroke. That is considered presumptive evidence of right-left shunt. You need not demonstrate.
The presence of the PFO doesn't prove it is the cause of the cause of the stroke.
No, it's associated.
Yeah.
It's
so
not a cause.
Cryptogenic, the word may continue, I don't know. That is
what they mean is decently we have evaluated the stroke in a way that there are no other plausible causes.
Yeah, I would highlight what Edwin said. We get very regular neurology referrals. It is guideline driven for PFO evaluation every stroke. I got an 84-year-old woman for PFO evaluation. Now that patient actually had a PFO. Now it is nice to define PFO for this purpose as a right to left shunt only. If it is a left to right shunt, in an elderly person, if you're trying to close it, you'll probably land in pulmonary edema. Yeah. Not only that you have benefited the patient, you will harm the patient. So all the indications only with right to left shunt. Yeah. I think we need to close. I think thank you, Sri. Thank you.
Next we invite Dr. Renu Kurup to explain the nuances of deficient RIMS ASD and how to tackle it.
Good afternoon, everyone. Good afternoon, chairpersons. At the outset, let me thank the organizers of ICC for giving me this opportunity. So today we are dealing with approach to ASD with deficient RIMS. Everyone knows ASD is the third most common congenital heart disease, and of 80% of second-term ASDs are suitable for device closure. Although we say that surgery is the gold standard, with negligible mortality and 100% success rate claimed, there has been a shift of paradigm for therapeutic strategy of ASD towards device closure in the past few decades, which can be attributed to the technical ease, the comfort of procedure, the lack of scars, and incredibly less morbidity, where they are out and walking within the next 2 days. What determines the results of catheter closure of ASD? The primary one is definitely the anatomy of the defect and how to image the defect, and most of all, the operator skills. So coming to the anatomy of the septum, everybody knows that the fossa ovalis defect is bordered by the superior vena cava, the aorta, the AV valve, coronary sinus, IVC, and the posterior wall of the atrium. So for assessment of ASD, for a device closure, first thing what we assess is the size, the shape, and the position of the defect. Is it a central defect or is it a peripheral defect? Is it an oval one or is it a round one? And do measure where it appears the largest, and from the firm edge to the firm edge. And what are these rims that we talk about? These are the tissues between the defect and the key adjacent anatomical structures, and that to the size of the rims as well as the floppiness or the thickness of the rim also matters. So when we look at the en-face view of the ASD, that is from the right atrium, you can see the aorta forms the supro-anterior, the AV valve forms the mitral forms the antero-inferior rim, then the postero-superior is formed by the superior vena cava RUPV, and the posterior, that's from the posterior wall of the atria, that forms the posterior wall, and the IVC or the forms the infero-posterior. So there has been many studies which have looked into the morphological variants of the ASDs, of which Podnar et al. Have defined, when they evaluated around 200 patients, they saw about 10 morphological variants. For us, the most important thing is that of this, the most commonest was deficient aortic rim, which contributed to almost 42%, and the central defects, which contributed to around 1/4, that is 24%, and the deficient infraposterior rim, that contributed 12%, rest all were less than 10%. So if you take a random patient, we are more likely to either see a deficient aortic rim or a central defect or rarely a deficient infraposterior rim. So others are all very rare. So we have to mostly tackle the ASDs with deficient aortic rims or mostly the postero-inferior rims. When you define the adequacy of rim, by conventionally it has been defined that you say a rim as deficient if it is less than 5 millimeters, and if it is adequate if it is more than 5 millimeters, less than 5 millimeters as deficient, and when it's absent you call it as an absent rim as depicted in these pictures. When it's a deficient infraposterior rim, you have always to take care that you are not looking at the eustachian valve as seen here. That should not mistake this for the inferior rim and measure this. Actually the inferior rim is here above. This is the eustachian valve. Because if you wrongly put the device here, you are routing the IVC to the left atrium. Some operators prefer to measure the total septal length, which aids in case selection and the maximum size of the device that can use. Because the LA disc has to be less than the maximum IAS length. The LA disc rim is about 6 to 8 millimeters larger than the vase. That is for devices which are 4 to 10 millimeters, your rim is 6 millimeters. That is, the LA disc is going to be 12 millimeters more than that of the waist. And for devices from 11 to 32, it is going to be 14 millimeters more, and from 34 to 40, it is around 16 millimeters more. So this is an ASD which everybody would like to tackle, which everyone would like to close. That is adequate rims. You can see that the posterior rim is there, the AV valve rim is there, the aortic rim is also present, though it's slightly floppy, and very good centrally located defect with the SVC rim is present, the IVC rim is. So this would be any intervention person's dream to have such an ASD for a device closure. But that is not the case that we usually deal with. So looking at the deficient rims, you can either, pediatrics mostly we use by transthoracic itself, and very rarely we go for transesophageal echo, but adults you will have to use mostly, you have to go by transesophageal echo, and I'm not going to talk in the details of assessment of rims because time does not permit. So looking at the transthoracic echo, you can see the deficient, almost the bald aortic rim here on transthoracic, and this is the T around 45-60 degrees, you can see the deficient bald aortic rim. And this is the absent IVC rim. Transthoracic echo, so you can see that the flow is actually, when you look at the color flow, it is flush with the wall. And this is the TE at 90 degrees, which shows a deficient or absent IVC rim. And this is a deficient superior vena cava rim, which is deficient. It's a small rim, but it's not totally absent, but it's deficient. And this is a deficient mitral rim. You can see there are two defects, and the lower defect you can see there is a very, very small mitral rim only, so this is not suitable for device closure. Very rarely we come across the one called as where there is a defective coronary sinus rim, which unless we look into it correctly, we will miss this. So when you go in a transthoracic echo itself, when we go posteriorly to see the coronary sinus, you can see there is a large defect. This patient had also had a large malaligned mitral rim. You can see the deficient coronary sinus rim. So ASDs where device closure is better not done include a deficient mitral rim because it impacts the deficient coronary sinus rim, absent IVC rim, and deficient multiple rims. Now there are some, what are the techniques that we used? The basic principle of the technique is that you should have something sending the device, sending the defect so that the LA disc does not fall into the right atrium before we deploy the right atrial disc. So this is the left upper pulmonary vein technique where you open up the LA disc inside the left upper pulmonary vein and allow it to remain there till you deploy the RA disc. This is the other one with the right upper pulmonary vein technique where these techniques can be used either in either of the aortic, where the deficient aortic rim as well as in deficient posterior rims. This is the balloon assisted delivery where you can use even a sizing balloon so that you dilate it across and deploy the LA disc and then the RA disc and then you deflate it. Actually what we do most commonly is the pushback technique that is once you deploy and you know that one of your rims have not been caught, you loosen it, you loosen your cable and push it towards from the anterior to posterior. You loosen the cable, make it around 90 degrees with the device and push it posteriorly so that the rim is caught. You can see that very clearly here. And this is really helped by the current Trevisio cable of Amplatzer, which helps us because it has a very mobile proximal 1/3. It's very flexible, so which helps us to deploy the device. So the device closure of ASD with deficient rims is possible in safe hands of an experienced operator, thorough imaging and understanding of the echo anatomical correlation, with proper selection of cases, adequate planning, thorough post and pre-deployment evaluation. Post also is very important because you have to look for in device embolization and definitely with the surgical backup. And not with the help of your team support and especially the person behind, that is usually your cath lab assistant. Thank you.
One question, a very simple question, in the sense, over the years,
Yes, sir.
with the number of so-called difficult ASD to be closed being sent to the surgeon, has it decreased or increased?
Decreased, sir.
Huh?
Decreased.
Decreased.
Just one point I would like to add. Renu was telling that TT may be sufficient for children and TE is mostly used for adults. But I would say to the young interventional cardiologists just who are just starting out, the first 50 cases at least should be totally done under TE. This is so that you learn to read the atrial septum very well in TE so that you get good knowledge of all the rims so that you know how you correlate your TT image with your TE image. And after you gain confidence of at least 50 cases, I would suggest at least first 100 cases, but definitely first 50 cases should be done under TE, however sure you are about the defect in TT.
I do agree with that.
This deficient rims, TEE is a must. It's a must. That is one. Another point I would like to make is balloon sizing. Balloon sizing is a technique in deficient rims. If there is a more than 2 millimeter indentation on balloon sizing, that is considered angiographic fluoroscopically sufficient. So
Rims.
yes, that is one point. 3D printing also may help if it is possible.
Thank you, Renu, for an excellent talk. We need to move on to the next topic.
Thank you, sir.
Shall we invite Dr. S.R. Anil to discuss sinus venosus AST closure? I have great pleasure in inviting Anil because I do not know whether the audience knows. It is seldom that we get an opportunity to ask somebody to describe a technique which he described first. When Anil's article I read in Catheterization Cardiovascular Interventions maybe 10 years ago, saying that sinus venous AST could be closed with a covered stenting of the SVC, I didn't believe it. I thought the pulmonary vein will get obstructed. So my next sinus venous AST meant for a surgery. I took to the cath lab, balloon occluded this SVC, and lo and behold, the pulmonary vein actually drained into the LA. And that was the beginning of the interventional closure of sinus venous ASD, and here is the person who described it, S.R. Anil.
Thank you, Dr. Suresh, for those kind words. I want to thank the organizers for giving me this opportunity to present transcatheter closure of sinus venous ASD. So the background was that when the first case I was in Apollo Hyderabad, my surgeon actually challenged me, see, Anil, don't talk about fossa ovalis ASD. If you can do sinus venous ASD, then come and talk to me. That is when this idea started up in my mind that we should tackle this problem. So understanding sinus venous ASD depends on the anatomy. We all know the sinus venous ASD is located high in the septum and where the RSVC end is RA. Embryologically, it is the result of unroofing of the RUPV as it drains into the right and posterior corner of left atrium. PAPVC of right upper pulmonary vein plus additional anomalous drainage of the middle or lower pulmonary vein can be associated. The surgical technique is essentially re-roofing with a pericardial patch, and that is what we intend to do using a covered stent. So the important thing is that the posterior wall of the superior vena cava forms the anterior wall of the right upper pulmonary vein. So you create a posterior wall for the superior SVC, automatically the right upper pulmonary vein will be rooted into the left atrium, provided the posterior wall of the right upper pulmonary vein is in continuity with the left atrium. So I will tell once more, the posterior wall of the right upper pulmonary vein has to be in continuity with the LA. If so, then if we provide an anterior wall, posterior wall to the SVC, that will form the anterior wall of the right upper pulmonary vein. There should not be additional pulmonary veins draining directly to SVC, which will get totally cut off when you use a covered stent. So that is one a prerequisite that we should follow. So this is the first the case report which we reported way back in 2014, where I have described the technique and the methodology to evaluate the sinus venous ASD to actually be suitable for transcatheter closure. The thing is very simple. You put a covered stent in SVC, inflate it nicely so that the lower end covers the ASD. The right upper pulmonary vein we will not get obstructed and drain into the LA. So this is the objective of the intervention. Essentially, case selection is on the basis of 2D echocardiography, transesophageal echo and CT angio. The initial cases, all patients, I got the CT angio done to make sure that there are no anomalous pulmonary venous drainage and to understand the anatomy essentially. So, the echo assessment is to see where the right upper pulmonary is draining. The vertical distance below the SVC to the upper edge of the ASD, if it is more than the transverse diameter of the where it joins the SVC joins RA, I usually don't do. In generally, if the lower end of the SVC to the upper end of the ASD is more than 1.5 to 2 centimeter, those patients are usually sent for surgery. If there are additional fossa valens ASDs are there, that may require additional devices. So this is how it looks like. The sinus venous ASD, you can see this is how it's a superior located ASD, and you can see the right upper pulmonary vein usually drains at the SVC RA junction. So this is the picture of the transesophageal echo. You can see this is the superior vena cava, and this is where the RUPV comes and joins. So the 90-degree view shows that the opening of the SVC right upper pulmonary vein directly into the posterior wall of the SVC. And once you cover that, the right upper pulmonary vein will drain into the LA. So how do we check this? This is again the CT pictures showing this superior vena cava. This is the superior vena cava, and this is the left atrium, and this is the atrial septum. And the sinus venous ASD will be superior located, and the RUP will come and join here. So this is again to show that where the SVC comes and joins the RA. This is the position where the right upper pulmonary vein comes and joins into the SVC, and this is the deficient posterior wall of the SVC. And when you put a covered stent here like this, you can see that the right upper pulmonary vein will drain into the LA and the SVC blood will go into the RA. So this is the pictorial depiction of what we intend to do. So the procedure wise, we check the PA pressure, the PVR, do an SVC angiogram, and then see the RUPV drainage, look for additional pulmonary veins. The T assessment essentially for the size of the SVC superiorly as well as where it joins the RA. The balloon testing is very important. We use a semi-compliant balloon, usually about 4 millimeters more than the diameter of the SVC. Usually previously I used to use the ASD sizing balloon, which is a 24 millimeter balloon. Now I use the Mustang or the ZMED balloons in the range of 16 to 26 millimeter diameters. Simultaneously, I put a catheter in the right upper pulmonary vein. In cases where I am very sure I don't take an additional transseptal puncture, but in case I am having a doubt, then I put an additional transseptal puncture and position a catheter within the RUPV. The angiography I do in LA and AP cranial view and the TE simultaneously. The three things which I require is complete cessation of the left to right shunt on balloon occlusion, unobstructed flow of the RUPV to LA, and no increase in RUPV pressure of more than 2 millimeter mercury pressure. So the procedure is done under general anesthesia and TE. I put a pigtail inside the SVC and do an angiogram directly. So this is the pigtail sitting in the SVC, and this is the catheter which is traversed across the upper edge of the ASD into the right upper pulmonary vein. Once I do a power injection to make sure that there are no other associated pulmonary veins, nowadays what I do is I do a partial occlusion of the SVC simultaneously so that I get a good injection. After that, I put the balloon. So this is how the balloon is placed in the superior vena cava, and I do an injection. Here you can see the catheter. I have put a catheter through the aorta into the pulmonary vein rather than take a additional transseptal puncture. And once I see something like that, that is not too good, because here I might potentially block the right upper pulmonary vein. I need to have a nice flow from the RUPV into the left atrium. I measure the maximum RSVC diameter. The length of the stent is decided according to the distance between the SVC just below where the innominator vein joins the SVC to the upper edge of the ASD. So that distance is the length of the stent plus additional 2 to 3 centimeters. So these are the measurements which I do. This is the ASD length. This is the diameter of the SVC as it joins the RA. And here is the balloon occlusion. This is another very important thing. I do the balloon occlusion and then measure the distance from the lower edge of the SVC to the edge of the ASD. Here you can see that the balloon occlusion has totally blocked the atrial septum. And when I turn rightward, you can see the right upper pulmonary vein is draining normally into the left atrium. So that is the right upper pulmonary vein draining into the SVC. You can see the round balloon which forms the posterior wall of the superior vena cava, and you can see how nicely the RUPV is draining into the left atrium. If I see a picture like this, then I don't have any doubt, I'll go ahead and stent the SVC. So what are the stents we are having? We have the CP stent, then we have the Cypher stent, and then we have the endovascular graft. And recently for all adults, nowadays I use the endovascular graft, which is easy to deploy, it stays well and it doesn't slip. The biggest problem with this stent, sinus venous ASD, is that the stent slips because there is no area to actually hitch onto. So the 3 cases recently I did using endovascular endurance stent of various diameters with various balloon sizing to look for the residual flow as well as for the drainage of the right upper pulmonary vein. So this is how it's done. That's a transesophageal echo we will do. The right upper pulmonary vein injection is done while the balloon is inflated. You can see how nicely the pulmonary venous flow is happening in the left atrium. And TE will simultaneously show me that the lower end of the device is, the balloon is actually blocking of the ASD valve. There's a few measurements which we take before we actually start deploying the device. This is how actually the stent graft is released. What I do is the upper end of the stent graft where the clip comes off, usually I deploy above the level of the innominate vein. This is the stent placement. This is how it looks after the stent is deployed. You can see the lower end of the stent is nicely hashed onto the IVS and the tiny residual flow you can see. That's the SVC flow, and you can see this will show the right upper pulmonary vein flowing into the left atrium after the stent deployment. This is how it looks on CT scan, how you can see the posterior left atrium and the sinus venosus is the stent has closed the ASD off. Postoperatively, I keep dual platelet therapy for 6 months. On follow-up, look for stent migration, thrombosis, residual flow, or drainage RUPV. CT angio is initially at least useful while selecting your patients for such procedures. Thank you so much.
Thank you, Dr. Anil. Just to add to this, you have been saying that this is very difficult to hold on.
Yes.
So what they have described now is as temporary suture technique.
There are different techniques for that. There are 3 ways of anchoring it.
Add on to this.
Yeah.
Please mention.
So one is you deploy a metal stent initially itself so that the second stent anchors on it. You can do one thing, put a first metallic stent at the upper end of the SVC, deploy the covered stent, and then one more additional stent to sandwich these stents. This is one way of anchoring it. Second technique is use a suture material. What we do is that you bring the whole stent out through the jugular vein, and then crimp the stent below the level of the balloon, pull it back, slowly deploy the stent and pull the stent into the proximal position. It's a very difficult thing to do, but I have done one case like that.
Thank you. This is one condition where Indians have scored much better than Western people. And Anil has done it, and our Muthukumar team and Shivakumar team has demonstrated that sophisticated high-tech imaging is not required.
I think one more short question. Just some time back, the left main stenting was considered as a sin. What about the sinus venous ASD closure? Will it get elevated to a class 2 indication or so in the foreseeable future?
I think so.
You think so?
I think so. See, 2014 it did. This started catching the imagination only recently.
Right.
Most of the papers started coming 2020 only.
Yeah. Dr. Titus?
Yeah, I have 15 cases, sir, now. I'll publish that. Yeah. True. True. Thank you, sir.
Thank you, Anil. Excellent presentation. And with that, I think we should conclude this session and move over to the next one. Thank you very much.
Thank you, sir.
Thank you, chairpersons and speakers. Before we move on to the next session, those who have given names for the poster presentations, please move towards the industry area. Thank you. And for the next presentation, I would like to call upon the chairpersons, Dr. George Tayil, Dr. Chiryan Koshi, Dr. Prakash N. Nair, and Dr. Ashwin R.M. The poster presentations will be starting now in the industry area. So those who are given their names for the poster presentation, please move towards the hall. Thank you.
Yeah, good afternoon, colleagues. Now, from the heights of PFO and ASDs, we are coming down to a different scenario. Now, if you consider the three important pillars of heart failure treatment, we have asked the first pillar, AC inhibitors, ARB, and now we have the magic drug ARNI. The second group could be beta blockers. The third group, mineralocorticoid steroid antagonist, MRA. Now we have another magic drug which got FDA approved many years ago, the so-called SGLT2 inhibitors. First, DAPA, glipizin and empagliflozin were the first two which have shown much efficiency in treating, preventing the heart failure and hospitalization for heart failure. We have the recent one, the sotagliflozin, which is not only the SGLT2 but SGLT1 inhibitor also. To highlight all these things, we have an eminent speaker, but I don't see the speaker. James is there. Okay, very good. We have a young, handsome cardiologist from Kottayam, Dr. James Thomas. Over to you, James.
Respected chairpersons, teachers, seniors, and dear friends. My topic is how the so-called new anti-diabetic drugs have changed my prescription. So when I thought about this, I passed out of DM in 2010, so maybe around 13 years back. This was my prescription, diabetic prescription for a diabetic patient with cardiovascular disease. It will be basically based upon metformin, sulfonylureas, maybe glucosidase inhibitors, pioglitazone, and simple insulins. Now, during that time itself, as early as in 2007, some danger signals were reported. This landmark meta-analysis, which was published in NEJM in 2007, reported that people who were taking rosiglitazone, when they did the meta-analysis of more than 40 trials, the relative risk of someone developing an MI was 43% higher, and the relative risk of someone developing CV death was around 60% higher. This was not substantiated in subsequent trials, but this made the FDA think that they should change the way these anti-diabetic drugs are put into trial. So they brought out a new guidance, that is in 2008, that the hazard ratio should be less than 1.8, and more importantly, they should include high-risk population in the trial. Till then, low-risk population were actually enrolled in this trial. In fact, in many trials, patients who were having CVD were excluded. And they should do the trial for at least 2 years, and they should report this. That is what they call as 3P MACE, or the 3-point MACE: non-fatal MI, non-fatal stroke, and cardiovascular death. So thus was born the era of cardiovascular outcome trials. We got a beautiful articles on cardiovascular outcome trials, the details and the history. And this was published in Indian Heart Journal 2016. It was published by our own Tiny Nair sir. And this is the CVOT timeline. The timeline showing all the CVOT trials till 2021. For easy understanding, we have kept the trials which did not show superiority. That is, those trials which only showed non-inferiority are placed on the upper part. And those trials in which the molecule was found to be superior to the comparator or placebo is kept in the lower part. Now we'll try to discuss three groups, that is the incretin-based drugs, which includes the DPP-4 inhibitors and the GLP-1 receptor analogs, that is the glucagon-like peptide-1 receptor agonist, SGLT inhibitors, and see if there are any insulins with better CVOT data. Now, how does this DPP-4 inhibitor and GLP-1 receptor agonist work? Basically, they are incretin-based. That means when we take food or when the intestine is presented with glucose, what happens is that the intestines secrete incretins. There are many incretins, and one of the most important incretin is the GLP-1 or glucagon-like peptide. What does GLP-1 do? It increases or amplifies the glucose-dependent insulin release. That is the first action. Second action is it also decreases the glucagon release. So the net effect is that the plasma glucose comes down. The most important part is for the proper action of incretin, the glucose has to be there. So it is basically glucose dependent. So how does the DPP-4 works? The DPP-4 is the enzyme or dipeptidyl peptidase, which is the enzyme which actually degrades this GLP-1. So this DPP-4 inhibitor, what does it do? Naturally, it blocks the dipeptidyl peptidase enzyme so that the level of the endogenous GLP-1 actually increases. Actually, there are so many DPP-4 inhibitors. Only when I tried to prepare for the talk, I realized that there are so many DPP-4 inhibitors. So many are approved and so many are in the pipeline. But if you see the data, we have only got data for a very limited number of DPP-4 inhibitors. We got the Savertimi, saxagliptin, Examine trial for allogliptin, TCOS for sitagliptin, and the Carolina and the Carmelian trial for the linagliptin. As I mentioned, all these trials are placed in the upper part. That is, all these trials have not shown superiority of DPP-4 inhibitors over placebo, but they have been found to be non-inferior with regard to MACE. So the Indian scenario, we got three molecules with CVOT data, saxagliptin, sitagliptin, and linagliptin. And the other molecules which we use, vildagliptin and teneligliptin, actually doesn't have any CVOT trial to back up its use. Now coming to GLP-1 receptor agonist. We got two groups. One is what we call as the exendin 4 analogs. This exendin actually found in the saliva of a lizard. So it's basically a synthetic drug. And the second group is based upon human GLP-1. So in the top part we got what is called as the exenatide and the lixisenatide. And the human GLP-1 based molecules are what we know more commonly, that is the once daily liraglutide and once weekly dulaglutide and the once day oral semaglutide. So how does these molecules fare vis-a-vis each other? We should remember that the GLP-1 receptor agonists are much stronger anti-diabetic agents. For example, the HbA1c reduction which we get from a GLP-1 receptor agonist is to the tune of 0.8 to 1.5%. In contrast, the HbA1c reduction offered by a DPP-4 inhibitor is only 0.5 to 0.8%. That is only half of that of GLP-1 receptor agonist. And the GLP-1 receptor agonist gives significant weight loss. In fact, many of the molecules are approved for the treatment of obesity even in those patients who doesn't have DM. Whereas DPP-4 inhibitor are weight neutral. They don't cause weight gain, but they don't cause weight loss also. And as I mentioned, the chance of hypoglycemia is much less with both these molecules because the action is basically glucose dependent. So why is there a difference between GLP-1 receptor agonist versus DPP-4 inhibitor? Basically, it's because the DPP-4 inhibitor, it actually elevates the endogenous GLP-1 because basically it inhibits the DPP-4 enzyme it elevates the endogenous GLP-1, whereas the GLP-1 receptor analogs provides a much higher pharmacological level. And this was the first landmark trial which showed that GLP-1 receptor agonist decrease CVD endpoints. That is the leader trial which examined the liraglutide. It showed that there was a significant reduction in MACE and most importantly decreased the CV death by 22%. The other two molecules which have got superior data, that is semaglutide and dulaglutide, both decrease MACE but they do not decrease CV death. So that is why the ESC recommends all three molecules, that is liraglutide, semaglutide and dulaglutide, for decreasing CV events, but for decreasing cardiovascular death, there is only one GLP-1 receptor analog, that is liraglutide, just called class 1 indication. And in India, we got the oral semaglutide, and the other molecules, they have not been found to be superior, they have been found to be non-inferior. And there are some new molecules also. What about their safety in heart failure? Because many often we will be treating patients who are having diabetes and also having heart failure. We should remember that the saxagliptin which we are using actually increases hospitalizations for heart failure. So we should not use saxagliptin in patients who are having heart failure. While GLP-1 receptor analogs, the data is actually neutral. What about in the CKD? Here again, linagliptin and liraglutide, they both are safe in CKD, so that we don't need to do much dose adjustment. One important problem of GLP-1 receptor agonists is that there is significant GI side effect, nausea and vomiting. Semaglutide can cause diabetic retinopathy and some minor side effect. And this is the Indian scenario. We got three molecules, liraglutide once daily injection, dulaglutide once weekly, and semaglutide oral daily. The biggest challenge is the cost, that is more than 10,000. So coming to SGLT inhibitors, now this is the scenario currently. So the cardiologist is actually taken the SGLT inhibitor from the physician. So I'm sure that we all know very well about the ASCVD risk, the importance of the beneficial effects in heart failure with rejection fraction, preserved ejection fraction, CKD. So we don't need to discuss much on that. We have been hearing this all along. I'll just try to highlight one point, that is, if you are using SGLT inhibitor not in heart failure but in ASCVD, we should remember that dapagliflozin doesn't have a role. Only empagliflozin has a role. And again, if you want to reduce mortality in patients who are having ASCVD by using an SGLT inhibitor, the only molecule which has got data is empagliflozin and not other drugs. So which one will I choose? Will I choose an SGLT inhibitor or a GLP-1 receptor agonist? In ASCVD, if you want to decrease MACE, you can choose either. Here it's showing only one molecule. You can choose either. For MACE prevention, you can choose SGLT2 inhibitor or GLP-1 receptor agonist. For heart failure, of course, SGLT inhibitor. Weight loss, GLP-1 is much better. For renal, SGLT2 inhibitor have got more data. And we should, of course, consider the other factors which we all know. And lastly, regarding insulin, only two insulins have CVOT data. That is insulin degludec and glargine, which have been found to be non-inferior. So which drug? And lastly, an academic question, that is, when we are treating diabetes, in someone who is having ASCVD, who is metformin naive, which should be the first drug which we are using? Conventionally, we have been using metformin, but based upon the superior data of SGLT2-1 and GLP-1 receptor agonist, the ESC said that we should introduce these molecules, either SGLT2-1 or GLP-1 receptor agonist, ahead of metformin. And only if HbA1c is not met, then only you should add metformin. But ADS still considers metformin as the first drug to be introduced. So it is a choice. ESC is slightly more aggressive. ADA still believes that metformin should be the first drug. So coming back to the question, did my prescription change in diabetes after all these years? I think it has. But for me, the first drug will still be metformin. Second drug usually will be an SGLT inhibitor because of the cost concern of GLP-1 receptor agonist. So what will be my third drug? Ideally, it should be a GLP-1 receptor agonist. But considering the cost, practically many often it will be the other incretin-based drug, that is the DPP-4 inhibitor. And if you need a fourth drug, then we can combine GLP-1 receptor agonist plus the DPP-4 inhibitor. Fifth will be basal insulins. And if the patient is not waiting for insulin, definitely I will be considering sulfonylureas and pioglitazone, etc. in select patients. Thank you.
Thank you, Dr. James, for the excellent talk. For want of time, we will give time to for one question to the audience.
Then, thank you, Dr. James. We switch on to the next topic. I think it is very loud back. We have to do something for that. Now, the lipid disorders that have been always an unresolved problem. How long we should reduce cholesterol, what drug we should choose, how much we should double the dosage of the drugs. If one drug is not sufficient, how will you proceed? Which is an add-on drug? What are the latest new molecules which have arrived in this scenario? To highlight all these problems, we have Dr. Sibu Matthew from Trivandrum. Over to you, Dr. Sibu.
Thank you, sir. Good afternoon. Respected chairpersons, my dear teachers and delegates, at the outset, I thank Dr. Vinod, Dr. Arshad and Dr. Mangalanandan and the ICC for giving me this opportunity to talk to you. So the topic is on when will I use add-on medications to statin, and probably I will add what are the drugs I am going to use. So lipid disorders are what we all treat, all of us treat. LDL cholesterol lowering is a central theme of the management of reducing the risk both in primary as well as secondary prevention. And statins are the first line drugs. But sometimes we may have to add drugs when the target is not attained, in spite of maximum tolerated statins, when there is statin intolerance, and whether other disorders are there like hypertriglyceridemia. And what are the targets to decide this? Basically, it is the LDL cholesterol target, but then there are non-HDL cholesterol and ApoB targets also, which we should be looking at. So if you look at a clinical scenario, a 50-year-old male with diabetes who had a myocardial infarction 9 months back is now admitted with a reinfarction. Patient was on regular medication and his atorvastatin dose was 40 milligram per day, which he was taking regularly. His total cholesterol is 140, LDL is 55, HDL is 36, triglyceride is 245. What will you do with this lipid management? So how to intensify or continue the same management, address the triglyceride, what will you do? So there are different guidelines available for us, the 2018 ACC/AHA, 2019 ESC guidelines, a 2022 update on add-on statins, and then a Lipid Association of India guidelines which was published in 2020. All are almost similar in the concept that we should risk stratify and should go aggressively in high-risk situations. So I will just give the basic summary because it is so confusing to go into the entire details of these guidelines because it will be confusing. The ACC/AHA divides into the treatment group into secondary prevention group with atherosclerotic cardiovascular disease and primary prevention group. And secondary prevention group has got a very high-risk group. Very high risk means at least two of these four, that is a recent ACS, history of MI, or ischemic stroke, or a peripheral vascular disease. If two of these four, or 1 plus high risk conditions are present, that means that the patient is very high risk. And they recommend that if the patient is very high risk, a 50% reduction of LDL cholesterol from the baseline to a target of less than 55 milligram per deciliter of LDL cholesterol, or an non-HDL cholesterol of less than 85 that is a target. So very high risk group. In high risk group, the target is LDL is less than 70, and there are intermediate risk group where the target of LDL is less than 100 and 100. So, very high risk group, you have to go very aggressively. Lipid Association of India is also giving similar guidelines where there is low, moderate, high risk and very high risk. But there is an extreme high risk group, whereas the Lipid Association of India says that you should reduce the LDL cholesterol to less than 30 milligram per deciliter in the category B. That means that in a patient who had a coronary artery disease with more than one high risk features, or a patient who had recurrent even within 1 year, you should go less than 30. ESC guideline also is going in the similar lines. Go extreme risk group, that is who had a recurrent event within 2 years, go to less than 40 milligram per deciliter. So ESC guidelines and Lipid Association, they say go for a very aggressive reduction. Why Lipid Association of India guidelines go for very aggressive reduction? Because we Indians are at a higher risk, 1.5 times to 2 times risk of atherosclerotic events compared to the West, and 50% of the death occur because of CVD below 50 years of age. 25% of myocardial infarction occurs before 40 years of age, and probably the dyslipidemia profile is also different. And the other target will be non-HDL cholesterol target as well as ApoB target. Non-HDL cholesterol is total cholesterol minus HDL cholesterol, which represents all the atherogenic particles, and the main protein embedded in LDL and VLDL is apolipoprotein B. And if you look at the non-HDL cholesterol and ApoB, it can be a stronger indicator of the atherogenicity of risk than LDL cholesterol alone. So for the treatment target of non-HDL cholesterol, so if you add 30 to the non-HDL cholesterol, suppose it is a high risk group, the target is 70. If you add 30, that will be non-HDL cholesterol target, and if you add around 10 or 15, that will be ApoB target. So there are 3 targets. One is the primary target which we all use are the LDL cholesterol target, then it can be non-HDL cholesterol target and ApoB target, and there are different levels for high risk group and extreme high risk groups. Okay. Now, so when a patient is having high risk, you should go aggressively and you should start early. That is what the data shows. And the choice of the drug depends upon the baseline LDL cholesterol level. Suppose the baseline LDL cholesterol level is very high, then to reach the target, you may have to go aggressively, probably with multiple drugs. What is the baseline cardiovascular risk? If the baseline cardiovascular risk is very high, then you will have to go very low. The target is very low. So such situations you will need aggressive multiple drugs. Then you have to look at the cardiovascular outcome data, cost and availability, frequency and method of administration, and patient preference. So what are the drugs available? The available drugs are, the first 2 are the oral drugs, ezetimibe, which is available for a long period, which inhibits cholesterol absorption, which is a cheap drug. Bempedoic acid is a relatively new drug, and a lot of new data have come. It's a ATP citrullinase inhibitor, and it acts just more like a statin, but it does not have the muscle symptoms. And then PCSK9, alirocumab and evolocumab monoclonal antibodies, PCSK9 inhibitor inclisiran, evinocumab. The next 3 drugs are injectable drugs, but they are extremely costly. And the other drugs, icosapent and fenofibrate, may be considered for a triglyceride reduction. Among these, outcome data, cardiovascular outcome data are there for the first 3 drugs, ezetimibe, that is Imbruvic, Fourier and Odyssey outcomes showed outcome data for PCSK9, and late in the same year, Clear outcome trial showed a benefit for bempedoic acid. So this trial was published after all the guidelines came, that is in 2023 only. So this is not included in the guidelines. So bempedoic acid, it improves long-term CV outcome, and it effectively reduces LDL cholesterol, both in primary as well as secondary group of patients. And nearly 50% of the patients' population were females and diabetics. And not only that, it reduces hsCRP, that may be useful in patients who are statin intolerant, and there with a mild increased risk of hyperuricemia and tendon rupture. And if you look at the combination of the drugs, if you see the high intensity statin reduces LDL cholesterol by around 50%. But if you add multiple drugs, you can reduce the LDL much further. So if you add bempedoic acid plus ezetimibe and statin, an additional 38% reduction may be obtained over the statin therapy. But if you want very high reduction, you may have to give PCSK9 inhibition plus ezetimibe. So how much do you want to reduce? If you want to reduce just around 20-25% in addition to the LDL, you may add just ezetimibe alone. But if you want to significantly reduce the LDL, if the target is not attained, you may go for a very high intensity drug therapy. So what do the guidelines recommend? The guidelines, ACC recommendation is that very high risk ASCVD, if the target is not attained, that is less than 55 milligram per deciliter is not attained. First is ezetimibe or PCSK9 inhibitor. Second is bempedoic acid. And third probably evinacumab in familial hypercholesterolemia. And similar recommendation is given for ASCVD not at high risk where the target is less than 70 and adult without ASCVD with more than 190 milligram per deciliter where the target is around 70. But in patients without ASCVD and patients with diabetes, PCSK9 is not recommended. Ezetimibe or bempedoic can be used. But after the clear outcome trial, especially when the PCSK9 is very costly, I think we can upgrade bempedoic acid as the first line drug along with ezetimibe before the PCSK9 monoclonal antibodies. So, but then we have to also see that before adding statins, before adding other drugs, we are adequately giving the statin. How often are we giving adequate dose of statins? A population survey showed that 50% of the patients do not give statins in diabetic patients. And actually the more commonly used combination drug was atorvastatin plus fenofibrate. And data from USA, UK as well as from India show that the usage of high intensity statin is probably to the tune of only 20 to 38% initially. So the use of statin is actually very low. Before stepping up statin, there is no role for adding other drugs. Statin intolerance can be a problem, but then when there is statin intolerance, you have to withdraw the drug and add the drug another statin or try to add as much possible statin as possible before adding the drug. So my recommendation will be with the patient who is having a high risk, if you start statin, start with the moderate intensity to high risk intensity as per the recommendation. If the target is achieved, that is fine. If it is not achieved, go to the maximum tolerated dose. And if there is a good control, then continue that. If there is target is not achieved, go for ezetimibe or add bempedoic acid. And PCSK9 inhibitors or inclisiran may be considered later only because of the cost as well as difficulty in administration. Regarding triglycerides, only if the triglyceride is more than 500, you may aggressively go for specific triglyceride lowering therapy. Otherwise, basically, it will be aggressive LDL cholesterol reduction. So our patient who has got a second event with an LDL cholesterol of 55 milligram per deciliter, his non-HDL cholesterol is 104, it is high. You have to give aggressive treatment. As per the Lipid Association India guidelines, probably you can go even up to 30. So step up statin to 80 milligram per day because he was only on 40, add ezetimibe, and if the goal is not achieved at 4 to 6 weeks, add bempedoic acid. And if still the triglyceride is high, you may consider icosapentae as an option. Thank you so much.
Excellent, Dr. Sibu, excellent. Now, a few points. I think the ezetimibe use is not adequate enough. I think we are underusing the importance of ezetimibe. Number one, we are giving atorvastatin. Rosuvastatin may be better in the sense up to 40 milligram of rosuvastatin. It is speculated that 40 milligram will be equivalent to almost 80 milligram of atorvastatin in terms of efficacy. Ezetimibe, as I told, is not adequately used, which is very good to be encouraged, number one. Number two, increasing better than, I think, doubling the dose of a statin. I think an addition of ezetimibe will result in better reduction than keeping on reducing the statin. Of course, the statin, the pleiotropic effects of statin are enormously important. PCSK9 inhibitors in our present scenario in Kerala or India, I think it is in terms of cost problems may not be affordable. Bempedoic acid is coming to the scenario now. We are starting using it. How many of our patients in Kerala for secondary prevention, you are telling about extreme risk, it should be less than 30 milligram per deciliter LDL, it should be very well. But how many of our patients in the clinical setup, we find that even for secondary prevention, after myocardial infarction, we are reducing the LDL less than 55 milligram per deciliter. I don't think even 80% of the Keralites.
So that is.
I think they are not reducing the LDL to that levels. I think the cholesterol control is very poor, despite all your aggressive talks and all. Can you comment on that?
That is the data is shown from all over the world. That is the data, the 3 trials is showed, the high intensity statin or use of statin is actually dismally low, around 20%. And actually, as Sir said, in high risk group, we should not reduce the dose of the statins. We should continue with high intensity statin. Sometimes we see that high intensity statins is actually reduced, and reduction of statin can actually result in an increased event rate. So not only even the statin usage is also not optimal. Then once we optimize, and if still the target is not achieved, then we should go for other drugs like ezetimibe or bempedoic acid. We are not addressing the LDL reduction or the targets very aggressively. That is what we are lacking behind it. Rather than the patient inertia, there is significant physician inertia in aggressively addressing this.
Thank you both speakers for their excellent talk. So we'll move on to the next session.
Thank you so much.
Thank you, chairpersons and speaker. Yeah. And for the next session, let's invite the chairpersons, Dr. Marcos KP, Dr. Shyam Shashidharan, Dr. Vishwanath V, and Dr. Vijit Pillai.
We have two topics in this session. The first one is about the calcium channel blockers by Professor Suresh, and the second one is about the new chain technology by Anil Kumar. I have informed that Anil Kumar is absent. If so, we will listen to Professor Suresh about the calcium channel blockers.
Respected chairpersons, dear friends, first of all, my thanks to Dr. Vinod, Dr. Arshad, and the rest of the organizing team for inviting me to talk to you on the newer calcium channel blockers in my practice. Calcium channel blockers belong to 3 main classes: the phenylalkyl amines, of which verapamil is the prototype drug, the benzodiazepines, of which diltiazem is the prototype drug, and the dihydropyridines, which are a large number of molecules classified based on their appearance into the first generation, second generation, third generation, and fourth generation. The first generation, of course, is nifedipine. The nitrandipine and felodipine, which people of my generation have used in the past, they belong to the second generation calcium blockers. And most of the newer calcium channel blockers belong to either the third generation or the fourth generation. Based on the tissue selectivity, calcium channel blockers vary in their vasodilator potency, with the dihydropyridines as a class possessing far more vascular-specific effects as compared to the benzodiazepines or the phenylalkylamines. There are actually 2 more subclasses which are no longer in clinical use now because of serious arrhythmic events as well as drug interactions. Calcium channel blockers belong to one of the most widely prescribed antihypertensive drug classes. In fact, this study, not this study, there are actually 3 studies from 3 different centers in India showed that calcium channel blockers as a class accounted for 35 to 55% of the market share of antihypertensive drugs, as compared to somewhere in the tune of 20 to 30% at best for most of the other classes of antihypertensives. Let's now understand a little bit about the calcium channels. There are three main channels, the L channels, the T channels, and the N channels when it comes to understanding the physiology of calcium channel blockade in the context of cardiology practice. L channels are long-lasting channels. All the calcium channel blockers possess the property of blocking L-type currents. They are long-lasting because they have a slow inactivation rate, and they are found in the cardiac and vascular tissues and mediate contractility, pacemaking, and the vascular tone. T channels are the transiently activated channels which are present in renal tissue and the adrenals. They are fast inactivated, and the N-type channels are the neuronal channels found primarily in the neurons of central nervous system as well as the sympathetic nervous system. They initiate neurotransmission by releasing norepinephrine from the nerve endings. They are also present in the renal tissue. Two more channels, P bar Q channel and the R channels, primarily neuronal type calcium channel blockers, important in neurological practice. So in short, the main calcium channels regulating high blood pressure are the L channels which mediate vasoconstriction, N channels which mediate sympathetic nervous system activity, and the T channels which are in the adrenals and adrenals mediating aldosterone synthesis, release, and salt and water retention. There are gaps in the therapy of hypertension with the conventional calcium channel blockers. These relate to inadequacies in renal protection, cardiac protection, vascular protection, cerebral protection, and of course the presence of distressing side effects. Some of the gaps in relation to inadequate renal protection relate to progressive glomerular hypertension, inadequate reduction in proteinuria, progressive renal parenchymal as well as vascular fibrosis, and inadequate suppression of RAS. Inadequate cardiac protection relates to vasodilatation-induced reflex tachycardia, suppression of the contractility of the heart, absence of antiplatelet effects, persistent risks of arrhythmia, etc. Inadequacies in vascular protection, progressive endothelial dysfunction, and accelerated atherosclerosis. Inadequate cerebral protection, increased risk of stroke and progressive decline in cognitive functions, and the side effects, notably peripheral edema and worsening of glycemic control. It is hoped that the newer calcium channel blockers, by virtue of their uniqueness of action and their differential effects on the various calcium channels, would bridge the gaps. Conventional calcium blockers are of the L type, that is amlodipine, nifedipine, whereas the newer calcium channel blockers have additional channel blockers. The dual channel blockers are either the L and the T type or the L and the N type. L and the T type examples are acylnidipine, ephonidipine, lercanidipine, to name a few. L and N type only cilnidipine. And there is also one drug which has triple channel blocker, L, N, T channels are all blocked, which is benidipine. They all reduce blood pressure to a similar extent to L-type calcium blockers. The L channel blockade alone, that's a limitation of amlodipine because intraglomerular pressure might rise due to a sole action on the afferent arteriole. They don't have actions on the efferent arteriole. Also, the heart rate increases and the myocardial contractility decreases. But when there is additional blockade of N and the T channels, it offers advantages. That is, it produces afferent and efferent arteriolar dilatation, preventing glomerular hypertension, better antihypertensive potency, and a myriad of pleiotropic effects. So as you can see here, all the calcium channel blockers possess L channel blockers, blockade, which translates into actions on the vascular smooth muscle, cardiac muscle, and the afferent arterioles of the kidney. Cilnidipine has additional N-type blockade. The only advantage is that it has actions on the neurons, and on the kidney, the action on the afferent and efferent arterioles are present provided there is no diabetic neuropathy. The L and T types have got actions on all these target tissues except the neurons, and the triple blockers have a universal action. Some of the detrimental effects of T channel activation are listed here. On the kidney, the vasoconstriction of both the afferent and efferent arterioles, release of renin, and facilitation of fibrosis. Adrenals, synthesis and secretion of aldosterone, and on the heart, it increases the heart rate and the risk of arrhythmias. So the benefit of T-type calcium channel blockade is that the inhibitory effects of aldosterone synthesis and release is a new mechanism by which T-type calcium blockers lower the blood pressure and protect renal function. Long-term treatment with RAS blockers can cause aldosterone escape, and T-type calcium blockers might aid in the control of this aldosterone escape. Benefits of added N-type blockade is that it leads to inhibition of cardiac sympathetic activity and less reflex tachycardia, equal action on the arteries as well as the veins, so less potential for pedal edema, and decrease in the renal sympathetic activity leading to significant efferent arteriolar dilatation, translated into improved eGFR and less proteinuria. So the newer calcium channel blockers in a short have multiple facets of action. They have superior renoprotective action, they have significantly greater reduction of renin and aldosterone, they have unique antiplatelet activity, they have superior cardioprotective action, they have superior cerebral protective action, and they also have vasculoprotective action as evidenced by the anti-atherogenic action and prevention of endothelial dysfunction. You must remember that most of the newer calcium channel blockers are oriental molecules, licensed for use in the East. So the trials and evidences with regard to the use of these are few, not too many. The listed here are 3 studies, mostly Japanese studies, one with relation to benedipine, one in relation to effonadipine, and one in relation to acylnidipine. They have all proved that there is potent antihypertensive effect. So the efficacy is proved beyond doubt. Also, they are extremely well tolerated, so the safety also is proved. But beyond that, do we have very, very strong data with regard to the endpoint reduction, outcome improvements, etc.? At the moment, the evidence is only slowly building up. It's not that they are not there, but they are scanty. Finally, coming to the pleiotropic effects of newer calcium channel blockers, they have a host of pleiotropic effects. Antioxidant properties, they stimulate nitric oxide production, they reduce insulin resistance, improve insulin sensitivity, better glucose metabolism. They are of value in improving the vasospastic angina by virtue of their actions on the coronary vasculature. It increases cerebral blood flow, might improve lipid metabolism, and a lot of other actions, anti-atherosclerotic action, reduces coronary plaque volume, etc. So in short, to put it in a nutshell, the newer calcium channel blockers, by virtue of their numerous additional mechanisms, numerous additional advantages, definitely, which are all listed here, they definitely make a case for the use of newer calcium channel blockers in cardiology practice. Certainly such use would be rational, logical, and scientific. So back to the original question, should I use the newer calcium channel blockers? As long as the guidelines retain calcium channel blockers as one of the first line drugs approved for the initial drug therapy in adults with hypertension, I think my answer is clear. Yes, is there any reason why I shouldn't? Particularly in the elderly, particularly in those with isolated systolic hypertension, also in those with chronic kidney disease, both as monotherapy as well as in combinations, in the backdrop of the proven efficacy, safety and tolerability, and possibly end organ protection and pleiotropic benefits. Thank you very much.
Thank you, Suresh. Any question from the floor?
Very elaborate and lucid talk, sir. Thank you. And just wondering, sir, with respect to amlodipine and the newer CCBs like cilnidipine and benedipine, for a absolute reduction in blood pressure, for the dose required for an absolute reduction in blood pressure, comparing amlodipine with benedipine and cilnidipine, do you think amlodipine is still more potent?
There is a popular concept that probably the newer calcium channel blockers are not as potent as amlodipine with regard to their antihypertensive property. But there have been some head-to-head studies between amlodipine and some of the newer calcium channel blockers, and they have found that could not find any reference which stated that the newer calcium channel blockers have superior antihypertensive effect as compared to amlodipine. But all of them state unequivocally that they have equipotent in reduction, as good as amlodipine. Equal quantum of blood pressure reduction, both to 24-hour ambulatory blood pressure monitoring, morning blood pressure readings, evening blood pressure readings, they have all found that they produce the equivalent kind of a reduction as amlodipine.
What is the mechanism of decreased incidence of edema in this newer CCBs?
The explanation that they offer is that the newer calcium channel blockers have actions on both the arterioles as well as the veins. So when you, just like the effect on the kidneys, when you have action on the afferent arteriole alone, afferent arteriole dilatation without the efferent arterioles getting dilated leads to glomerular hypertension and more proteinuria. The same kind of situation in the legs, arteriolar dilatation, more of blood going into the tissues, venous dilatation is not there, it translates into edema. But the calcium channel blockers, the newer calcium channel blockers are credited with the actions on both the arterioles and the venules, and that is why probably there is less of edema.
Thank you, sir. Thank you, sir. Thank you.
Thank you.
Questions?
Thank you. So we shall move on to the next session. And the chairpersons for this session are Dr. Rajalakshmi S., Dr. Binu SS, Dr. Deepak Davidson, and Dr. Mohammad Rafi.
Good afternoon. Now we have two interesting topics. And the first one is on bifurcation stenting. What is new in 2023? I call upon Dr. Rajivi to give away the talk.
Thank you, ICC, for this topic. This also had me thinking what is new in 2023. Anyway, we'll go on. The first and foremost, I would say in 2023, what is new in bifurcation angioplasty would be the EBC main 3-year results was announced just a couple of months ago. As we all know, EBC main trial is a large trial which looked into two arms, one being stepwise provisional stenting for left main bifurcation, exclusively left main bifurcation, the significant left main bifurcation with side branch stenosis, into stepwise provisional and dual stent strategy. And we all know the results of EBC1, 1-year results were announced a couple of years ago, which showed stepwise provisional versus a systematic dual stenting in LMCA bifurcation lesions was almost equal. That provisional was as good. There is no need for a dual, it was similar. But coming to 3-year results, what happened was in 3 years, each individual plots, the death MI, revascularization, they started widening, the gaps widening for benefit with a single stent strategy rather than 2 stents. So EBC 3-year follow-up, it is still being continued into 5 years, showed good outcomes at 3 years with bifurcation left main PCA with a single stent provisional crossover, no difference in 3-year primary endpoint, almost twice as much TLR in systematic dual stent group. Only 20% of patients with provisional group required a second stent. And it is not necessary to decide number of stents before you start. That was the message. Now, we'll examine what is the stepwise or sequential provisional. The first step being DS implantation according to the main vessel distal diameter. We may or we may not wire the side branch depending on the complexity of wiring. An initial pot with a compliant balloon so that the possible part of the stent is well expanded. And at the end of pot, if there is a good side branch flow, TME3 flow, there is no side branch stenosis, and if it's a small vessel, side branch is a small vessel, yes, done. That's the end of procedure. If it is not so, at least one no regarding this, then we go on to side branch interventions in the form of rewiring of side branch. If there's a jail wire, keep it and wire the side branch with a fish hook technique or reverse looping technique. It is necessary to rewire to the distal cell so that we don't have to create a new carina. And then side branch opening with a appropriately sized side branch balloon. Here the options are either we can dilate with a balloon or we can do a kissing. And then a final pot, that is mandatory, a repot. And then reassess the side branch. If the side branch flow is good, TME3, no side branch stenosis, yes, accept it, well and good. If no, there is dissection, significant dissection, flow is compromised, then bail out with a dual stent strategy. This is a stepwise professional. Now, further, the KISS group, this study looked into whether doing ballooning into side branch, does it really make any difference? In single stent, we are talking about single stent strategy in non-left main lesions. but, with leaving just treating the main branch alone, or keeping the side branch open with a balloon in a side branch. The results showed that in non-left main lesions, there is no point in going on dilating side branch. You can just treat the main branch itself, and then if you dedicatedly, if you do side branch intervention in the form of either kissing balloon or a side branch balloon, it just increases the radiation, increases the contrast volume, it becomes more cumbersome, that's all. So the KISS group said provisional stenting in routine non-left main bifurcation has good short-term outcome. Routine side branch dilatation is not beneficial. It reduces procedure time. Possibly the long-term follow-up will say the definite results. Now, that is true. That is, we don't have to do side branch intervention in non-left main bifurcations, accepted. But generally in left main bifurcations, even with provisional crossover stenting, we generally try to open the strut with these two options. Either a pot followed by kissing and then repot, or a pot with side branch ballooning or pot. Now, what is something new in this? We'll just look into this. See, basically, pot side pot reduces, that is, you do a side branch ballooning in between two pots, reduces side branch obstruction, there is less malopposition and better ellipticity. A pot kiss pot goes a little further, even though it's cumbersome, it opens the bifurcation cells better. But recent registries, the largest registries of left main bifurcation and other ways, have not shown any benefit for routine kissing, unless we take two stents. See, if you are taking two stents in bifurcation, yes, it is mandatory to have a final kissing inflation. But otherwise, kissing inflation does not do any good. Now, there is some data. This is something which happened, which came this year. That is, this is a study which looked into angioscopy, OCT, and benchmark data on using pot, side branch dilatation and pot versus pot, kiss pot. And it said the basic things that study was that if you can see, if you do benchmark and angioscopically, if you do pot, side pot versus pot, kiss pot, the kiss pot had better side branch preservation. The side branch stent, that ostium was well covered if you do a pot, kiss pot. But that difference was very minor. So this study said both these are acceptable, both side pot or pot kiss pot, both achieved good result. And pot kissing balloon inflation pot resulted in better distal main vessel expansion and side branch ostial scaffolding, possibly. And side pot preserved the proximal main vessel circularity. So I take it as if I am more concerned about the distal and side branch ostium, I would suggest we can do a pot kiss pot. And if I am more concerned about the main vessel and proximal vessel, the pot side pot is ideal. But whatever is the option, a repot is mandatory. Now, some new concept for pot in 2023. We all know why we do it. We pot to optimize result in the main branch, to prevent guide wire tracking behind the stent struts during recross, and reduce obstruction of side branch. Now, the position of pot balloon, where it has to be placed. Ideally, see in that picture you can see, ideally the pot balloon has to be at that what is called the carina cut plane. That is, you can see the plane marked there, carina cut plane. The working shoulder of the balloon should be at that plane. That results in the next B, the second picture, the opening of the struts at the side branch ostium. But it may not be always possible to have a correct positioning at that carina, but you can make it a little proximal. But it shall not be distal. So either that carina cut plane or little proximal. Just a hint about, see these balloons, all these balloons are not similar. See, some balloons will have that shoulder might be corresponding to the distal edge of the marker. And for some, it may be the proximal edge of the marker. It is better to familiarize this with our balloons before doing the pot with that balloon. And a recent meta-analysis, this is the latest this month, of all the bifurcation data said overall two stents techniques were not significantly better in terms of clinical outcomes in general. But dedicated, if there's a significant side branch narrowing, then a dedicated stool stent may be opted. And so like this, see, if you have a complex bifurcation lesion involving the side branch, then there is no option but to go for a dedicated two-stent approach, which may be a decay crush or a any varieties of crush, nano crush, mini crush, or Eculon. Now, this is the evidence for upfront two-strand strategy. I will not go into details of it, but there is robust evidence. If you have a complex bifurcation, then the way out is possibly a dedicated two-strand strategy. Now, in this, interesting to look into the data of this. This is the latest 3 large trials of left main. Interestingly, how many numbers turn to two stents? Now, roughly the numbers are around 22 to 28%. So, rest of them all provisional continue to be a single stent, and almost a quarter of them would go into two stents. Now, what are the recommendations of LMCA, interestingly, over these years? This is interesting to see that over the years, with the accumulating evidence of left main PCI, we can see that at 2021, this is not latest, we are yet to go, but possibly ESC has said it is class 1A and ACCHA class 2B. And the algorithm for left main bifurcation, I will not go into this slide because the next talk is expressed basically on that. And I'll just wind off with a couple of cases. This is an LMCA provisional. You can see there's LMCA is not a very large vessel. And a pot was done a 3.5 mm balloon. And this is the final result. So I could achieve a vessel size 3.5, which was acceptable by IVUS in this. That's a little basic case. The next, I think, is a little more complex. This is a trifurcation left main. Again, since the lesion was possibly only to the LAD ostium, it was decided to go for a provisional single stent strategy. And it was dilated, initially post-dilated with an NC balloon, and then a pod was done with a semi-compliant balloon at 4.5. And the final IVUS showed that main vessel was well expanded at 4.6. That pod balloon, non-compliant balloon, took the vessel size to 4.6, and the circularity is maintained. So overall, my take-home points, I think, would be provisional strategy may be used in all bifurcations except where anatomy is complex or there's a large side branch. The provisional stenting is not an approach, it is a philosophy, and it is not necessary to prejudge lesions and predict outcomes of strategy. The result in main branch is more important than side branch. Pot should be part of every bifurcation technique to respect the fractal geometry. For final pot, especially, don't pot too distal. Kiss pot may have slight advantages over the side pot. And there should always be low threshold for using intracoronary imaging for optimal results. Thank you.
Thank you, Dr. Rajiv. It was a lucid talk. Just one simple question. When you are considering a single stent strategy initially, is there any situation where you predilate the side branch?
Generally, the recommendation is to avoid predilatation as much as possible, because the risk of predilatation is that if you have a dissection, the wiring of the side branch, all this, generally we end up putting two stents. So, but if we anticipate, see, the procedure, we anticipate difficulty in dilating the side branch ostium. See, side branch ostium is calcific. If the side branch is diseased, then I think we may predilate. But general recommendation is, as far as possible, avoid side branch predilatation. You can rewire, then avoid predilatation as far as possible.
Then in bifurcation lesion, where the side branch is not significantly diseased, you have gone for a single stent. When you put after single stent stenting, is it necessary that you should open up the struts?
Yeah, that is, see, presently, in the left main, if that lesion is more than 70% in left main, and non-left main, if it is more than 90%, it is suggested that we open up the lesion. Just to open up the struts, if there is no lesion, that's, madam, I think you think that, just to open up the strut, if there is no lesion in ostium, some operators prefer to do it in left main. The possible reason being, if, see, the person has an event in circumflex later to access the vessel, but then generally it is not recommended in the sequential provisional.
Okay.
Even for left main?
Even for left main, yes.
No routine opening?
No routine opening of struts.
I think in left main, it may be after, with imaging, if you can see.
Yes.
I meant for the other lesions, big side branch, etc. left main with imaging, if you see that the circumflex ostium is okay, you can leave it.
Yes. All this recommendation is now being modified with physiology and imaging. See, if there's a non-left main also, if it's a large branch, if you feel significant in 90%, the physiological studies have very well shown that even angiographically very severe lesions may be physiologically non-significant.
Any questions from the audience? If not, shall we move to the next talk?
Thank you.
Thank you, Dr. Rajiv. Next, I welcome Dr. Rajesh for his talk on contemporary left main intervention, how to do.
Respected chairpersons, I want to thank Dr. Vinod for this opportunity. My topic is contemporary left main PCI, how to do. If you look at the left main histopathology, you find the atherosclerosis is mostly located in the lateral walls because of low shear stress. The carina is relatively spared of atherosclerosis. The predominant mechanism of side branch compromise after left main LAD crossover stenting is secondary to carina shift with smaller contributions from plaque shift. A shallow bifurcation angle is associated with a greater likelihood of carina shift. Kissing balloon post-dilatation will reposition the carina and improve the situation. If you look at the evolution of left main PCI over the last 25 years, important technological advances in the form of improved balloons, improved guide wires, has significantly impacted the outcomes of left main PCI. Intravascular imaging has definitely impacted the outcome of left main PCI. It's mandatory that every left main PCI should have an imaging done, whether it's IVUS or OCT. Provisional stenting is the game, and unless you have a very diffuse or complex disease in the side branch involved extending more than 10 millimeter beyond the ostium, you would consider an elective second stent strategy. And drug-eluting balloons also have impacted the way left mains are being treated. If you look at technology, this is an example of a pod balloon. If you look at the pod balloon, the shoulder length is only 0.6 millimeters, whereas conventional balloons have a shoulder length of 3.2 millimeter. So this reduces the chances of carina shift and plaque shift when you use a pod balloon for dilatation. All of us addressing left main should also have extensive knowledge of the stent expansion which is possible with different makers. For example, Ultimaster 2.25 stent can go up to 4.5, but other stents may not go up. For example, Zynes does not go up to 3, only goes up to 3 in a 2.25 stent. So just talk about tips and tricks in performing IVUS and left main PCI. JL4 guiding catheter is recommended to prevent deep intubation of the left main stem. Decannulation of the guide catheter from the left main stem is required to image the left main ostium. For tight lesions, pre-dilatation is recommended to prevent potential occlusion of left main and instability during the procedure. Tips and tricks in performing IVUS in left main: pass wires in both the LAD and circumflex and do a pullback. It's important to visualize the ostium of each vessel before you plan your two stent strategies. All of us know this 5, 6, 7, 8 rule of optimal stent expansion after a left main PCI. What about OCT in left main? The high resolution OCT is useful in assessing stent sizing, lesion complexity, calcification, stent apposition expansion, and coverage of side branch ostium with stent struts. FFR, all of us who do left main, if you have a significant side branch compromise angiographically, even if it's more than 75%, only 1/4 of them will have a physiological significant stenosis after if you do a functional assessment with a pressure wire. Our experience over the last 25 years, around 410 patients underwent PTCA to left main, 27 patients underwent primary PTCA for left main with ST elevation MI. 90% of patients received second generation drug-eluting stents, 74% of patients had left main bifurcation disease, 15% had ostial or mid-shaft disease. True bifurcation lesions present 24% of patients, 65% of patients with bifurcation disease underwent provisional stenting. The most in the distal bifurcation, the technique used was predominantly mini crush in 32%, Culotte in 24%, T-stent in 24%, DK crash was only in 4%, and drug-eluting balloon was in 4%. Mean age of patients was 62 years, 43% of them had chronic stable angina, and 57% had ACS at presentation. And 7% of the patients underwent left main PDCA due to iatrogenic left main dissection. 90% of them had unprotected left main, and IVUS imaging, intravascular imaging was only used in 15% of patients, which is abysmally low when you're considering left main PCI. But what about aorto-ostial lesions? The guiding catheter preferred is a JL 3.5 or JL 4. Select the best view to profile the left main ostium. It's an apicranial or iliocranial view. Additional wire can be used as an extra support wire. Critical ostial lesions would require a low profile balloon for initial dilatation. Cutting balloons should be used in left main ostial lesions because of the elasticity and the recoil which happens when you do a left main ostial disease. And a few millimeter projection of into the left main ostium is considered. And select a stent with the good radial strength and less longitudinal deformation. This is a case example of a 67-year-old female with hypertensive who presented non-ST elevation MI in March 2021. This is the angiogram showing critical ostial left main disease. We initially wired the LAD and the diagonal to get good support, dilated with a 0.85 inch Nick nano balloon. It's further expanded the 2.5, 12, and 12 balloon, and there was a good recoil even after the initial balloon dilatation. Then we proceeded to a cutting balloon, a 3x10 cutting balloon, followed by a deployment of 4x12 stent, and then expanding the stent with a 4.5 to 8 NC balloon. We got a reasonably good result after that, and the patient is doing well at 3 years of follow-up since then. The second case is a 58-year-old male, hypertension, dyslipidemic, class 2 dystonia effort, and the angiogram showed a critical ostial left main disease. It's a trifurcation disease with a bulky distal left main. Again, here we used direct stenting with a 4x12 stent, and it expanded subsequently with a 4x8 NC balloon, and we got a good result. Patient is doing well after about 3 or 4 years of follow-up now. And this is a 71-year-old male with diabetes, anterior wall ST elevation MI, anterior wall MI with complicated cardiogenic shock. He was intubated and shifted to the cath lab. He had a critical distal left main disease involving the ostium, the circumflex, and the LAD, and here also a proximal LAD disease. This patient, initially we dilated the circumflex ostium with a 2.520 balloon. Then the LAD was also treated with the same balloon. The long stent, 338 stent, was placed from the left main into the distal LAD. The circumflex was rewired and dilated the 2.5 to 15 balloon. Again, another stent was placed in the circumflex ostium, a 318 stent, and the final result was good. The patient was extubated and shifted to the ward. Unfortunately, after 7 months of follow-up, he suddenly was brought dead as a casualty. He probably had a stent thrombosis. This is another patient who had a critical distal left main disease, a trifurcation. He had an anterior wall ST elevation MI. He was treated with a 2.5 and 22 stent, and this was a straightforward stenting. He didn't have cardiogenic shock, and he improved, and he was sent home. The third patient was a 56-year-old male, dyslipidemic, was an anterior wall ST elevation MI in 2019, and this was the picture, a total occlusion, the LAD, a critical left main disease, and the wiring was done, both the LAD and circumflex was wired, the initial dilatation of 2.5 and 15 NC balloon, and then we planned a mini crest strategy. We placed a stent in the circumflex and a LAD stent. The circumflex stent was deployed first, then the LAD stent was deployed after recrossing, and then the final kissing balloon inflation, and we got a great result after POT with a 408 NC balloon. So these are 3 examples of patients who presented with ST elevation MI and a left main disease. Another patient, a 67-year-old male, diabetes with a CKD creatinine of 3.3, anterior wall MI 2015, severe LV dysfunction. He had a previously PDCA stent LAD and circumflex done, ASCT implantation November 2019. He presented last month with acute coronary syndrome. Angiogram showed a critical disease of the circumflex ostium, a distal left main involving the LAD, ramus, and the circumflex. So this was a patient had a zero contrast PCI done using IVUS guidance. initially crossing into the circumflex because the extreme angulation was difficult. We used a Crusade double lumen catheter to cross into the circumflex, just dilated with a drug-eluting balloon, and then we proceeded with an IVUS of the LAD into the left main, and then IVUS showed extensive calcification. The patient had IVL used and subsequently had a 3.515 DES implanted, just post-dilated with a pod balloon, and the final result was good with a good opening of the struts and a good lumen in the left main. This OCT done after, IVUS done after that showed a good expansion and no lack of good expansion of position. This is another patient with a 50-60-year-old male, a diabetes hypertension, the extensive anterior wall MI in 2017, PTC stent to proximal LAD. This was he had a lesion in the circumflex stent. He initially had a left main to LAD and a circumflex stent done 1 year ago. He presented with the symptoms and a new lesion in the circumflex. This patient was treated with initially with a low-profile balloon. Subsequently, a 3.5 and 12 NC balloon was used. A kissing balloon was done, and a 3.5 20 impact drug-eluting balloon was placed in circumflex ostium, and a final kissing was done. We got a good result. The patient is doing well in the 4th year of follow-up from now. There's another patient who had a 42-year-old male who presented with critical disease of the circumflex ostium after LAD stenting in another hospital. And this time we used a 1.25 and 15 balloon for dilatation. The patient was treated with the 3 to 15 drug-eluting balloon with a good result. The patient is also doing well, leading an active life at the 5th year of follow-up. The other patient who had a...
Rajesh,
yeah.
Can you just hurry it up?
Yeah, just a lot of examples to show, but I'm just concluding. This is another patient who presented with anterior wall ST elevation MI, critical left main disease, treated with a NC balloon, and then a final cutting balloon, and the final result was good with a good opening of the struts of the previously implanted stent and a good long-term outcome. Can I take 5 minutes more? What's some good? Yeah, this is an example of a culotte stenting done in a patient who presented with anterior wall MI, and we had a good result after doing the culotte stenting.
Can you come to your conclusion slides, please?
I'll go to the conclusion slide, yeah. Sorry, I got a lot of examples to show, but so I just want to conclude that if you're treating a distal left main bifurcation, a provisional stenting strategy is the preferred technique unless you have a disease in side branch extending more than 10 millimeter in a very complex distal left main disease. IVUS runs on both the limbs of bifurcation is mandatory. A long side branch disease extending more than 10 millimeter from the ostium, prefer a two-stent strategy. Upfront two-stent strategy, DK crush is the preferred technique. In single-stent strategy, the kissing balloon dilatation may not be unreasonable. In two-stent strategy, kissing balloon dilatation is mandatory. I want to thank each one of you for your patient hearing.
Yeah, that was an excellent talk. You have covered all the related points. Okay, thank you. Any questions from the audience? Then we'll conclude the session. Thank you very much.
Thank you. Before we move on to the next session, I have been informed to inform you, the people who are in the tea area, please be silent. The noise from the tea area is affecting badly to the seminar. Yes, let's move on to the next session. And I would like to invite the chairpersons onto the dais, Dr. Anil Robi, Dr. Sheba George, Dr. Patmaja NP, and Dr. Ravi Cherian Matthew.
First talk is on SFA occlusion, extending my default strategy by Dr. K.P. Balasan. Over to you.
Thank you, Chairpersons. Let me at the outset thank all the organizers for giving me the opportunity to talk to you on a relatively simple question, but difficult to answer. SFA occlusion is extending my default strategy. That is what we have to look into. And it's the nicest time to discuss this because most of you are in the narcolepsy. Maybe somebody is in the cataplexy stage as well. So it's very easy for me to put this question into the audience and tell you what I feel is the answer. But before going into the answer per se, SFA occlusion is the leading cause of peripheral occlusive vascular disease. We all know this. It is the most common area which is occluded in a peripheral occlusive vascular disease. And most common site of involvement is the adductor canal. Nearly half of this group are asymptomatic. To pick the base of the iceberg rather than the tip is the actual question which we have to go into the detail. Whether symptomatic or not, that is the most important aspect. The morbidity and the mortality are significantly higher for this group because they also have other comorbidities like coronary artery disease, cerebrovascular disease, and whatnot. See, for simplicity purposes, the SFA as well as the popliteal artery, we combinedly call it FP segment because once the common femoral artery gives off the profunda, the SFA is a straight tube most likely and most often, and only very few branches, muscular as well as skeletal branches come out of it. So it's a straight tube. It's a long tube as we put it. But the importance is that it is subjected to compression as we can assume because of the leg movements, the thick muscles which are there, most powerful muscles, circumferential changes which occur with the movement of the leg, the longitudinal compression and the shortening, elongation, along with knee flexion as well as hip flexion. MR angiogram shows that at least 13% shortening can happen in this femoropopliteal segment between supine to fetal position and 60% torsion with hip and knee flexion. See, all these add on to the complexity of the intervention as well as putting a stent there, a metallic thing there. This is a schematic representation of what I said already. The first percutaneous treatment, even though we call Grenzik as the father of angioplasty, Daughter and Judkins in 1964, few years before that, treated critical peripheral arterial disease with tapered PTFE dilator catheter. Actually, this should have paved way for Grenzik's exercise as well. The problems of balloon dilatation, as we all know once we are into this area, the flow limiting dissection as occurs in any other part of the body. When you dilate an artery, there is a chance of dissection. The vessel recoil, similar to what we see in coronary arteries. The inadequate results, again similar. Acute closure, that is also there, even though much less than what we see in coronary, because this is a larger vessel. So basically things are almost similar, but they are not that similar, basically because these are very large vessels and the physiology as well as the trauma produced there is entirely different. The long-term patency after dilatation, balloon dilatation, depends on all these factors. The presence or absence of diabetes, the poor tibial runoff, this is the most important. If you have a patient with significant runoff disease, tibiopopliteal system is significantly diseased, tibioperoneal system is significantly diseased, there is no linear flow reaching up to the plantar arch, then you have significant chance of long-term, the chance of long-term patency is rather grim. The patient is in critical limb ischemia, then again the chance of going into reocclusion is much high. Long lesions, as anybody can assimilate, inadequate results with angioplasty, balloon angioplasty. But after all this, the chance of 1 year primary patency in the best case scenario is only 33% with angioplasty alone. So that paved way for the stimuli for better strategies. There are better strategies as we see in coronary angioplasty as well as atherectomy, laser, various types of atherectomies, cutting, scoring balloons. But the problem here in peripheral vascular disease is the lack of availability as well as the lack of experience, lack of data, because the large number which we have seen in coronary are not seen in peripheral arterial disease, as well as the stocking of the cath lab with all the requirements for a peripheral vascular disease is possible only in very few centers. So that is the main problem which we come across in treating patients with peripheral occlusive vascular disease. The complexity, cost, complication, deficient data, availability, all this have not shown significant improvement with the atherectomy, laser, cutting balloon. This may be the reason for all this. The right side things which I highlighted may be the reason for it. Then the drug-eluting balloon. Of course, we had the drug-eluting balloon. We still have it. It may be important. But again, the data is not that much. Of course, the bare metal stent. We have used it for many years now. We will see what is happening with that. We have the PTFE covered stent, which was used for some time. We will see what is happening with it. And of course, the drug-eluting stent. The BMS, we had initial few pilot studies as well as the initial studies which happened in 2000 onwards, which showed that no significant improvement with the, the initial was head-to-head comparison with angioplasty with bare metal stent. That showed bare metal stent was equivalent to angioplasty. The RCT, which Schillinger et al. Published in 2006, nitinol stent versus angioplasty alone. Mean length was short, mind you, it was short, less than 13 centimeter. 12 months follow-up, restenosis 37% versus 63%, which tells you that there was significant improvement with BMS. 2 years, 45% and 69%, significant improvement. This is a schematic representation of that. The Resilient trials, almost similar data. The multi-centered registry, which we had from Japan in 2014, again showed significant large number of group, significant improvement with freedom from restenosis in stented group. The problem with bare metal stenting is stent fracture, as occurs in any other, because of the tremendous pressure which the stent has to undergo. But it was not that much as is expected, it was only 0.9% in various trials. The ISR was the most important thing, almost up to the tune of 1/3 at 12 months. Option for ISR, PTA alone, grim prognosis. Cutting balloon, no significant better with that. Atherectomy lacked validation. We had some other special stents which are also available, the Abbott Supra stent. Instead of the nitinol tube, woven nitinol wires were used. That showed significant improvement in primary patency, but lacks validation in the long-term data. The PTFE covered stent, the Vibrant RCT in 2013, again, no significant difference. We had the drug-eluting stent, we are still having it. Paclitaxel only found to be useful, the other drugs were not found to be useful. The Silver PTX from Cook and Eluvia from Boston Scientific. The Cook stent is not available in India as I get it. I have not used it. Eluvia is available, but I have not used it. The data are available for both. Head-to-head comparison is also available for both. Availability, that is the most important aspect of it. You cannot keep all these stents in all the sizes in your cath lab. The cost, again, the procurement, the shelf life. All these are very, very important in attending to a peripheral occlusive vascular disease. So coming back to the question, is stenting my default strategy? This is a case which I did in 2008 for critical limb ischemia. A very long lesion, almost starting from the femoral head to the end of the adductor canal. That is the knuckle and re-entry with coronary wires. The re-entry with microcatheter. the final stent, final balloon. But the balloon result, sorry, I cannot go into that aspect. Okay, let me see. Okay, that is a balloon. Now that this is a post-balloon scenario, you're not happy with it. So we did a long stent, long two stents here. Oh my God. Yeah, that is the final result. Pretty good result, and the patient had good recovery after that. He had critical limb ischemia with tissue loss, which healed over time. Now I'll tell you another case which I did recently, 2013. This is a short segment lesion at the end of adductor canal with good tibial runoff. That is the wiring. You can see the how exactly I wired it. So it's a simple lesion, whereas the previous lesion was very, very difficult for wiring. So even the wiring, the way in which you wire and finally do before you do the balloon, that also, here I did just a balloon and avoided stenting. So my strategy in FPPTA depends on so many parameters: the clinical profile, length and complexity of the lesion, distal runoff, how easily I could cross the lesion, balloon results, long dissection, acute closure, suboptimal results, recoil, all these requiring stenting as a strategy. But otherwise, I might, if it's a short one, I might do balloon angioplasty alone. Thank you. So my strategy has not changed from 2008 to 2023. That is what I wanted to tell you, because the strategy is the same. The common sense most often tells you what to do. Thank you.
Thank you, Dr. Balakrishnan, for the nice talk. So what do you want to say? The shorter the lesion, better the result, or longer the lesion, better the result?
If I can proceed with a very short lesion, very short procedure, good result at the end, not a significantly diabetic patient, good peripheral runoff, I will stop with that. Otherwise, even if I get a good result, no peripheral runoff, critical limb ischemia, I would rather stent it. This is this I may not be doing it in 2008, but now I'll be doing it, especially after the introduction of drug-eluting. I have not tried, even though I have not tried it. If anybody has any experience with drug-eluting stenting in peripheral occlusive vascular disease, somebody can tell.
I just want to ask your opinion about drug-eluting balloon in peripheral.
Drug-eluting balloon, it has a primary patency rate is the same as any other balloon. Okay. The long-term patents, we don't have that much data. That is a basic problem.
Recently, I had a case of a long lesion, like starting from the CFA bifurcation to the lower leg, more than 250.
Sorry, I didn't get you.
A long lesion, more than 250 millimeters. So the vessel was only 5 millimeter in diameter. So what I did was I did drug-eluting balloon in the lower part and the upper part I stented. Like.
Yeah, the below populated lesion strategies are entirely different.
It's above
okay.
Long lesion.
Okay.
Because I think now a lot of drug-eluting balloons are available. So
yeah, drug-eluting balloons are available, but again, the long-term data is not that much.
I have one question. For the SFA, you prefer to use a short balloons for pre-dilatation or use a long balloons? And how do you feel like short balloons causes more dissections or a long balloon causes less dissection? And then you go at a low pressure or a high pressures?
Yeah, that is one thing, very important aspect actually. See, basically, I would rather go with at the maximum, taking the size of the balloon, starting with the size of the balloon, 1:1 is usually this thing. If you take a larger balloon, there is more chance of trauma to the vessel. Now, the length of the lesion, basically it depends on your length of the lesion. So it doesn't matter much because the overhang, anyway, you can it's not that much as we see in a coronary artery disease. Second, the third question which you said, the inflation, deflation. It has to be low pressure inflation, long inflation as well as slow deflation. This is the usual pattern if you want to avoid a stenting. Because chance of recoil as well as dissection is much less with low pressure inflation and long inflation.
because I face more of dissections with short balloons. Even though the lesion is very short, using a short balloons, I feel I face more of dissections. When I use a long balloons, I don't get much dissections and I go at a low pressure. That's why I asked.
Rather than the length of the balloon, it is the pressure inside the balloon which is much more important. If you go at a very high pressure.
No, I usually go at a very low pressures.
Yeah, don't go. This strategy is not to go above normal pressures. Maximum normal pressures.
Thank you.
Thank you. Thank you for the patient listening.
On how should a cardiologist take care of his health? What are the checkups one should do? We have the AMP person, Dr. Johnny Joseph, who says exercise is life.
Thank you, Chairperson. Respected Chairperson, respected seniors. So, it is tea time is over. Let us get energized. So, how we should take care of our own health, maybe our family members' health? What are the lifestyle plans one should do to prevent the most crucial, most lethal CAD, CBA complex, plus cancers, maybe a complex of non-communicable disease, diabetes, hypertension, CKD, NASH, CLD, and finally the neurodegenerative. I do not have the answer. But what we need is, we all love to have a long life expectancy with a good quality of life, so that the health span and lifespan gap is minimal. We call it marginal years. There, what is our quality? That is the most important thing as far as me is concerned. I am in my marginal years. If I can enjoy things in life, that is the most important thing. And we had a survey in the Kerala CSA a few years ago. Many of you answered. We categorized people into the top class master athletic class. Nobody was there with a VO2 maximum more than 60. Then we had a 13% who said that we are fairly above average, athletic or even above average, enjoying life. And then many were average, and about 50% was suboptimal or even non-starters or non-gainers. So I also was in the same category, maybe at my 40s. We had a Kottayam IMA survey which told that the greatest loss of our fitness was between 30 and 40. The important life, we start our married life, we are becoming a specialist and enjoying life. And I might have had insulin resistance at that age. I was bulky. My cholesterol was 312 at the age of 35. First time I am checking because I thought I was very much fit and healthy. With good genetics, I had fatty liver probably, borderline SGPT, a drop in the, they all said, that means my vitamin D is down. So, this is me in 1980, third year student, member of many teams, 4 or 5 college teams, and many prizes in different athletics. But becoming a cardiologist, I have acquired prosperity, and my mother ridiculing me along my sister in 2011, 13 years later. And our team, this is our team. We think that we are in the upper class of that blue line where we have got a higher VO2 max. Any person in that line, the upper class, and if we are maintaining his exercise, is likely to even live longer and have a higher VO2 maximum even at the age of 75 or 80, which is much above the VO2 maximum of the average person at their 30s or 20s or 30s or 40s. So we know that in fitness, 2 things are most important for life, longevity as well as quality. One is aerobic fitness, which is the VO2 max, and second is muscle strength. And these are the most important predictors. So, in fact, I had lost that in the middle of my life At the age of 30, when the first time I did TMT, I could complete 12 minutes and even beyond that. And then it went dropped. Then I started by around 45, 50 or 60. I started to get it back and was happy to have in August 23, I had a VO2 max 17.52 max with a VO2 max of about 42, 47. So it is possible to regain VO2 max even if you lose it. That is a good thing about it. And this is my Bruce 13.1 minutes. The second thing I want to tell is that this treadmill is not for that I am doing treadmill every day. I do not do any treadmilling or running or even for the past 10 or 15 years. There are other ways of getting aerobic fitness. That is the one thing I would like to highlight in my talk today. And looking at the second aspect, the muscle strength. Even at the beginning, I was a thin person, not having much of a muscles. I hated gym. But in this group, you said but along with the muscle strength, other things also matters. The person on the right of the cup is Mohan Varghese. He was athletic, robust, but he died at the age of 39 due to a sudden massive heart attack by South Africa. He was smoking all throughout in between the matches, I remember. So other lifestyle factors also contribute. And even if you lose muscle strength or even if you are not having a good muscle strength, it is regainable or even achievable even if you start late at the age of 60 or 70. The person on the right is my relative whom I have trained at the age of 72, who was in very poor condition. Now he is enjoying. And it does not need many the complex gym materials, only a few, a barbell and a squat rack and a few other things that is needed. We can enjoy at home and have a fitness. Of course, one has to start slow, right from the beginning. I started about 8-10 years ago with the body weight exercises. And then something called kettlebell, simple things like farmer's walk. Then I graduated up. That is to prevent injury. So when we start, there is if you look at the picture, the first picture, there is a zone where the load is small, but you won't get any training. Then it's an optimal stage where you get training, but beyond that you get injury also. Then you gradually, if you go up, your training zone becomes higher and higher, and your injury zone becomes lower and again higher and higher. And even if you are in the optimal zone, if you go suddenly, increase your load, you are likely to get injured. So progress slowly, gradually, you can have very, very high limits to go. And how many minutes? How many? 2 minutes. Okay, then I am born in a sleepy village, very beautiful. Lot of activities was there. That is why maybe I am in the team of many a times. At the same time, the same background, many of my family members did not have any of the lifestyle problems. My father, mother, nobody diabetics, my brother. Only person who had a diabetes or hypertension was the person on the right, the young man, who is also a doctor. So we both of us were changed our urban life, and even despite our some activities prescribed by the WHO, we had all of this problem. I thought maybe the urbanized life, diets, lack of sleep, stress of medical education, competitive examination, being a member of a CSI itself is a stress nowadays, and suboptimal sunlight, low fiber, prolonged sitting, which is called gluteal unloading, and a lot of processed food, good things. Probably it has changed. Nowadays there is a talk about microbiome all along. It has changed the microbiome, and maybe there are many factors we do not know contributing to the much of the lifestyle diseases. And today morning I had karkada kanji, enjoyed, and the padankanji also, along with the nuts. So these are things which I added recently upon. And there are as I said, there is not only one way of running, cycling, for to get a VO2 max or to have your mitochondria energized or even an increase in number, you can, any type of a high intensity exercise also is a good stimulus for that, and I am fully convinced about that. And again, the strength training part also, it is quite enjoyable. And there are, I start with something called a high intensity circuit, small 7-minute workout. Many people still benefited for that. And even body weight exercise are also good for HIIT. And this paper, I am very convinced that this paper from Mayo Clinic changed the way we think. The HIIT itself is as good or more good than the routine regular cardio in having a mitochondrial function, improved fitness, VO2 max and everything. And this is the thing which I am using for my cardio, only kettlebell, 1 or 2 type of exercise. It takes only about 3 to 5 minutes for that. And again, for my resistance training, strength training, I use barbell, and that also for a few minutes. So that is, if it is in the higher side, we can achieve if you have a time challenge. If you have enough time, you enjoy all your running, cycling, and combined work, everything. And I am not going into the investigations for lack of time, but I know many of you know about what are things we can to have a safe exercise program. And so in short, I have mentioned you that gradually scaling up your training for VO2 max, either in the aerobic part with intermittent high intensity runs, or with other types of exercise. Scale it up, and fiber route which you seek for, and optimize your sleep, optimize your distress tolerance, have more sun life, and team up your family members. Thank you all.
Dr. Johnny Joseph, that was more of a personal disclosure, I thought. It's wonderful, and congratulations for maintaining it. But what should a cardiologist do as a routine test to assess that person's health?
Can I go back 2 slides? As I mentioned, routine lab work, maybe something we can add upon is that for somebody in the pre-diabetic age, you can have your serum insulin tested, and something called Kraft, the old Kraft test. You load like a GTT, it may be normal, but do simultaneous serum insulin. The serum insulin curve goes too high. That means you are in the pre-diabetic, and you are going for all sorts of problem with the insulin resistance, which I think is the mother of all the many lifestyle diseases. And secondly, you can have your DEXA scan, body mass index, apart from things like that.
Okay, Joni, thank you. Thank you for the talk.
Thank you, speakers and chairpersons. And before moving on to the next session, let me remind once again to those who are in the tea area, after having tea, please do disperse. The noise from the tea area is affecting the conference which is happening here, so please remain silent. Yes. Moving on to the next session, I would like to call upon the chairpersons, Dr. Pradap Kumaran, Dr. Placid Sebastian, Dr. Shifaz Babu, and Dr. Jittu Sam onto the dais.
Bijilal, actually no introduction is required. He is one of the person doing the maximum valves replacement, percutaneous valve replacement in the state. Bijilal, please.
Thanks to the organizers for inviting me. After this live story of Dr. Joni, it might seem little boring talk, but still bear with me. So I'll go straight to my case scenario. This is one case which I had to intervene recently. This is a 77 years old man with a severe aortic stenosis, moderate AR. He underwent TAVR with a 34 millimeter evolute valve 6 months back. Before that, he had PCI2 LAD and Ramus intermediates. He had a failed attempt at CTO to RCA. Now he came with a worsening of angina. Now he came with a worsening angina. So he needs some sort of intervention, coronary angiography and all. So let us look at the data. Let's look at the scope of the problem and available data. So you know the risk factors for both these overlaps. The risk factors for aortic stenosis and risk factor for atherosclerosis overlaps. So it is not surprising that these patients develop progressive coronary artery disease after TAVR. So data show that 2% of the 1 year recurrent of CAG or PCA is 2% post-TAVI with a 5-year incidence of around 16%. And we know that TAVI is no longer a procedure confined to the elderly. As more and more younger patients get recruited to TAVI, the lifetime risk, lifetime management of aortic stenosis and CAD becomes more important, and they are more likely to come up to the coronary angiography table. So the ESC consensus about TAVI is that TAVI and PCA before TAVI is that for all the proximal lesions, significant proximal lesions, it is better to do PCA before TAVI. But if PCA is planned after TAVI, the transcatheter heart valve of choice, that is either the low frame valve or the high frame valve, and the implantation technique with a special attention to the commissure alignment should be aimed at preserving easy coronary access. So what are the factors affecting coronary re-access after TAVR? The first one is the patient factors which are not modifiable. Those with smaller aortic sinuses, the risk of the ease of accessing the coronaries is a little difficult. But then comes the more important one, that is the device procedures, device parameters which we can control a little bit to an extent. So what when we do when we implant TAVR in a low coronary situation, narrow sinus situation, the only thing which we can do is we can try to put the valve a little deeper, but it got its own problems with a little increased gradient, little higher risk of pacemaker, but the future access to coronaries may be a little better. Like rather than putting it at the annulus, put it a little deeper so that the coronary access through the top cells of the open, through the first strut of the balloon expanded valve may be easier. Rather than suppose the coronary is here, we'll find it little difficult to intervene. But if it is little lower implantation, then it will be easier to implant. This is especially true with a self-expanding valve where it is not a cylindrical valve, whereas self-expanding valve is a tapered valve. You can see that a 29 millimeter self-expanding valve at the waist portion is only 23 millimeter, and a 34 millimeter the waist portion is only 24 millimeter. So what is corresponding to 29 millimeter self-expanding valve will be a 26 millimeter My valve or a 26 millimeter Edwards Sapien valve, which is a cylindrical valve, just 26 millimeter at the bottom, 26 millimeter at the top. But whereas if you can put a 29 millimeter evolute valve, the waist portion is only 23 millimeter. So that will give us 1 or 2 millimeter extra space to access the coronaries post-procedure. So when you look at the implantation and the leaflets and all, you see that you can see count from below 1, 2, 3, 4, 5. So the top portion where the leaflets commissure starts is at the 5th level. So that is at the height of 22 millimeter. So this you deploy the self-expanding valve around 3 to 4 millimeter below, so that at the height of where the commissure ends will be around 18 millimeter for this. And for a balloon expanded valve, the height is around 21 millimeter. We put it 2 millimeter down. So again, the height is around 18 millimeter. So there is not much difference in the height at which the commissure starts in a self-expanding valve or the balloon expanded valve. And always we will have to access through the struts in a self-expanding valve, whereas only 50% of times you will be able to access above the frame in a balloon expandable valve. But you must know that My valve octacore is a new valve which is different. It is short frame. It got only 2 struts instead of 3 struts in the classical My valve or 4 struts in the Sapien valve. The octacore has only 2 struts, and the first strut is totally free, and the total height is only 17 millimeter. So it is much more easier to access the coronaries with the new generation My valve. That is My valve octacore. So this shows the height of this ceiling skirt in different valves. You see, it is the lowest with the My valve octacore, but that's not shown here. Sapien got a 17 millimeter height, whereas for the Medtronic it is around 22 millimeter. But if you take the 7th diamond, where also there is a connection, it is around 23 millimeter. The open cells design of the Accuray Neo and the large struts of the Navitor system of the Abbott facilitate coronary access. So coronary access is slightly better with these 2 valves. But coming to the more important thing is that of the commissural alignment. This is also very important. Suppose the coronary is here, which is easier to access. Suppose the coronary is against the commissure, it is difficult to access. So you must do something to align the commissure, not against the coronary. So if the commissure is aligned like this, there is a post there, there is a lot of tissue there, we can't access the coronary directly, we'll have to go through one of these side struts. So lack of coaxiality, lack of support, those things happens here. So you must try to do something to align this commissure away from the coronary. That is the commissure alignment technique. So this self-expanding evolutor valve, there is a C paddle. So there are two paddles which connect to the connector. So one of them has the shape is like that of the letter C. So that is against the commissure. So we must devise something so that this commissure, this C paddles is not against the coronary. So we have techniques for that. We try to keep this what is known as a hat mark on the outer curvature while you go, and on the outer curvature in the LA view, the aortic annulus, that generally aligns the commissure away from the coronary. This is not clear, always possible with the data shows that this is not reliably possible with a Sapien valve, but the MyValve Octacore has again come with a very CT-based technique loading technique to obtain commissure alignment, which is their data shows that it is possible in close to 80% of patients. They will look at the mid portion of this right sinus and that angle which forms the horizontal. So this is 3 o'clock. This is an acute angle. This is an acute angle which is 2:35 p.m. This is like 2:58 p.m. So they load the valve in such a way this angle is taken into account, and once this takes that 180-degree curve in the aorta, this commissure comes opposite, not against a coronary. So coming to the access of the coronaries, for self-expanding valve, you know that this aorta has become smaller after the self-expanding valve is implanted. It is like more of like a tube, a smaller tube. So it is difficult to cannulate with a EBU catheter and support catheters, where you need more of a passive catheters. And we must aim for the 4th, 5th, or 6th node from here. 1, 2, 3, 4, 5. Count like this. At the 5th node is the 5th diamond is where the ceiling skirt ends. So we can try to 4, 5, 6. One of these we can try to cannulate the coronary through that. Whereas for a balloon expanding valve, it's not like that. The cannulation is more easier. We can use whatever catheter we need, but maybe generally one size less. Suppose you use a 3.5, you can try to use a 3 EBU instead of 3.5 EBU. So that is given here also, the same thing. And the coronary engagement, as I said, we can try to go against the 4th, 5th, or 6th node from here, and try to go just beyond into the sinus. And if it is not going, then you can use a wire support, either a J wire or a stiff thermo wire, which is helping that. And once you do that, we can wire the coronary with one of the coronary wires and put the gate deeper inside. But it's more important to use an anchoring balloon or a liberal use of gate extension that will give us more support to do this procedure. And catheter disengagement also, we have to be careful because the catheter may be catching on the new aortic leaflet, and when you pull it, if it is difficult to pull, if you pull very hard, it can lacerate the leaflet. So you should be careful. You can use a wire and do that. So I'll go to my case here. I first did a aortic root angiography and saw the anatomy. You can see a left main stenosis in this patient. This patient had a prior IVUS which showed a great, at that time the left main area was around 5.9, so this left main was not intervened at that time. So what I did is I wired this. I used a JL 3.5 gate, and after that wiring and all, I can see do better angios and can clearly see the lesion. It was pre-dilated, then used a guide liner and did an IVUS also, and through the guide liner, tracked the stent and did the procedure with a reasonably good result, and the final IVUS, everything could be done. So my conclusion is that coronary angiography and PCN patients is after TAVR is generally easy, but can be challenging in patients with narrow sinuses and commissure malalignment, especially if you use a self-expanding valve. And the guide, regarding the guide catheter, passive gates, not active gates. passive guides and get liberal use, so use guide extension catheter to get adequate support. That will be the ideal strategy for complex PCA in these patients. Thank you very much.
Bijilal, wonderful talk. Actually, I just want to have 2-3 comments and questions to you. In your experience, how many cases the patient came back with after TAVR, whether you require an intervention, number one. Number two, any data published that against balloon expandable versus self-expandable, there is a difference which created real outcome difference. Number three is actually, if you do an ostial stenting in these cases, how do you protrude the stent out of the valve and how much millimeter extra?
Generally, coming to your first question, in my experience, out of around 65 patients, I had 2 patients coming back with a recurring PCI. 2 patients had a recurred PCI after out of the 65 patients. And coming to the last question, osteostenting is done when the coronary, when the leaflet occludes the coronary after TAVR. It is generally done on the table during TAVR, where you must have at least 2/3 of the stent inside the coronary. The anchoring is only going to be by that leaflet, which is at the ostium. There is no lesion to anchor the stent. So a good amount of stent should be inside the coronary. So you take a little longer stent, suppose it's a, maybe you'll go into the LAD and come up to the ostium like that, and you need at least some 3 to 4 millimeter protrusion outside the coronary ostium.
Well, in that time, when you expand the osteoproximal part of the stent, will you have a real difficulty of opening the stent to the maximum, or
I never had to do that. I never had.
Data?
They advise that it should be expanded very well, that ostium should be flayed very well.
Self-expandable versus balloon expandable, when data available from the international level?
On what?
On the post-TAVR stenting.
Post-TAVR stenting, generally it is the cannulation and all are going to be slightly difficult in a patient with a self-expanding valve compared with the balloon expanded valve.
So what is the usual ideal timing of intervention in a patient of TAVR? Should we do it before routinely or?
Yeah, ESC consensus statement is that suppose you got a proximal coronary involvement, then it is better to go for stenting before. It's a class 2A indication rather than planning for after.
And any incidence of the device getting dislodged or disfigured with the coronary intervention later after TAVR?
I don't think it will be stable after. Once the TAVR is completed, the device will be stable. It is extremely unlikely to dislodge with during coronary intervention.
Any questions from the audience? If no questions, we'll move on to the next speaker. Dr. Bijilal, thank you so much for your lucid presentation.
Next topic will be orbital atherectomy. How will I do? By Dr. C.D. Ramakrishna.
Good evening, respected chairpersons, dear friends. Let me thank Dr. Vinod, my dear friend, for giving me opportunity. Topic. Sorry. Topic given to me is orbital atherectomy, how I will do that. But luckily, 10 days back, I got one patient who was willing for orbital atherectomy. So I just changed the caption, orbital atherectomy, how I did it with case as an example for the discussion. So we all know that calcium is the enemy of interventional cardiologists. If there is calcific severe coronary artery disease, definitely outcomes are worse in all aspects like death, cardiac death, MI, TLR, MACE, all we have bad outcomes if there is significant calcific coronary artery disease. So we have a lot of devices as well as techniques to deal with calcific coronary artery disease like non-compliant balloon, high pressure balloon. We can go for scoring or cutting balloon. And we have the atherectomy device like rotablator as well as orbital atherectomy. Orbital atherectomy device is available in Western countries many years back, and here it's received FDA approval. But thanks to Involution company, it is recently available in India. For 6 months back, it was available. I think most of our friends might have done that. So with calcific coronary artery disease, if there is no tortuosity, thrombus or dissection, we can go for PTCA. But sometimes wire is crossed, but balloon is not crossing. But sometimes balloon is crossed, but we cannot dilate the lesion. We have to go for some device like atherectomy device. So whether it is orbital or rotational, its balloon is uncrossable, preferably orbital. But if it is large vessel, we can go for orbit. But we can treat any vessel size like 2.5 to 4 mm with either orbital or rotational atherectomy. But each has its own advantage as well as disadvantages. So difference between orbital and rotational atherectomy. So orbital atherectomy advantage is a bidirectional treatment. We can treat forward, backward, or antegrade or retrograde cutting, whereas it is rotation, it is only front cutting, monodirectional burr. So orbital is only one burr size. It's 1.25 mm classic eccentrically placed crown. So whereas but in that we can use any size vessel like even small size or larger size just because of the orbiting. If it increase the RPM, it will orbit like this so that it will treat the larger size vessel. But in rotational, we have to go for multiple burr size ranging from 1.25 to 2.5 mm. So one more advantages of orbital atherectomy is that is Viper wire advanced. The Viper is a user-friendly wire, just like our workhorse floppy wire. This is O12 in the shaft and O14 in tip. So it is very friendly wire. We can take that wire just even for the wiring the vessel. But whereas in earlier Rota, not Rota Pro, we have the O1 tip and it is on shaft. It is very flimsy wire. If you just press it, it will bend, and we have to face a lot of difficulty in that wire. So one more advantage is the electric power source. So switch on. So there is a power source whereas in rotation we have to go for arrange the cylinder with the nitrogen pneumatic power source. And one more advantage is it is one and eye coordination is enough, whereas foot pedal is not required as rotational, and only 2 speeds we can set, 80,000 RPM or 1.2 lakhs RPM based on the vessel size. Bigger the vessel size, we go for 1.2 lakhs so that it will orbit in more like patients, so that it will ablate the lesion. And whereas in Rota, we have the different RPM we have to set. So one more, then technique, that orbital, it is very slow treating the vessel. So very slow ablation, like slow forward and backward, 1 to 3 millimeter per second. So 2 mm forward and 1 mm backward. So key to the success is very slow ablation we should do. Whereas in rotational, we can go for picking forward or backward motion. So some advantages based on its mechanism, like differential circumferential sanding orbital mechanism. So differentiates the calcified plaques, and when it's orbiting, so if it is a healthy tissue, it won't touch that vessel. Only it ablate the plaque. So variable size of lumen modification depending on the speed, different vessel size can be treated. And non-occlusive continuous flow of blood during the orbiting and bidirectional treatment, as I have discussed earlier. So coming to my case, she was elderly female, she was diabetic, and severe symptoms, effort angina function class 3 to 4, and normal LV and renal function. And she had TVD, but not at all willing for surgery. So she had calcific coronary artery disease and tight lesion in the distal LAD. And fluoroscopically, we can see the significant calcium. When in Rota pullback, IVAS pullback showed more than 278 arc of calcium, both superficial as well as deep calcium. So this is Diamond Black 360 coronary orbital atherectomy system. It has that pump or orbital atherectomy system pump. It is a power source as well as connect that IV line to that pump. Then this Viper side lubricant. It is actually for the continuous lubrication of while doing the ablation. So you have to dilute with saline. Usually it is a 20 ml for the 1000 ml saline. And this is a device. So this is that system device. It has knob to this switch is for selecting the speed. And if you press that switch for 3 seconds, we can activate the glide assist. And this is a wire. So first step is you have to dilute that lubricant with 500 ml. So 10 ml diluted with 500 ml. Ideally, it should be 1000 ml with 20 ml lubricant. So steps, I will discuss the steps that initially sometimes pacemaker may be required, and hemodynamic support if patient is having poor hemodynamics or low ejection fraction. Then engage the guide catheter. It is 6 French guide catheter is enough. supportive guide catheter should be taken and should be coaxially engaged. Then wiring, there is usual Varco's guide wire we can take with the microcatheter. After that, it can be exchanged for Viper wire. Or even because, as I told earlier, it's a very good user-friendly wire. We can direct wiring with Viper wire flex tip. So this is a wire, as I discussed earlier, it's a 014 tip and 012 sharp, very good wire. So in my case, this was a microcatheter with the floppy wire, exchange for the Viper wire. Then sometimes you can use the vasodilator to prevent the slow flow. And after that, you have to test the device. So test the device, this is the device. So after taking the device, this is connected to that lubricant solution. And you take the knob backward, and usually it is 7.5 ml. You take the knob backward, and it can lock it like counterclockwise. You lock it, clockwise you lock it, and make it counterclockwise to unlock. And after that, you switch on the pump. And then you use connecting the 20 ml syringe to that system, that all the air can be taken back. And then you see how the lubricant flows and see the flow. After that, you take this device to the coronary artery, and with the glide assist, we can easily take the device to the so press it for 3 seconds, we can activate the glide assist, and then we can easily take the device to the proximal deletion. So advanced ground proximal deletion, and fix the Viper wire, and sometimes glide assist, we can take the help of glide assist. It's unable to deliver the crown, maybe different reasons, so we can go for larger glide or coaxial engagement, and glide assist definitely will help. So in this, then treating the vessel, that is, you move that knob very slowly. That is very important. Very slowly means 2 mm forward, 1 mm backward. 2 mm forward, 1 mm backward. Should be very slowly, so that, and after 15 seconds treatment, wait for 30 seconds. That is very important. In between, you have to take the pause. So after 25 seconds, BP will come, and after that 30 seconds, up to 30 to 60 seconds, we have to wait, again restart. So if it is a very long lesion, definitely it is time consuming. We should have a lot of patience. So lock this one wire, speed adjust, and knob, move the knob forward and backward. Duration 15 seconds. After that, interval of 30 to 60 and wait. Monitor ECG for pressure change and pressure changes. Check shoot if required. Suppose patient has pain and all. Then one more thing, you can cross the lesion, but it should wait, stay away 10 mm away from the tip. After that, you can go for antegrade cutting or retrograde cutting, especially iodocoastal lesions, or in tortuous vessels, you can for retrograde cutting. Then the most important point I have discussed, it is a very advanced, very slowly. For slow advancement, you will get the larger luminal gain. And then always very important, duration is less than 50 seconds, wait for 30 seconds. And always the pause between the runs, so that will give the very good result. So finally, after remove the crown, we can remove that lock and take it out. Sometimes maybe glide assist may help. Check shoot to look for slow flow or dissection or embolization, and replace with the other wire, and you can go for balloon angioplasty. So in my case, I did pre-dilatation 210 balloon, then 2.5 30 to 23 drug-eluting stent was taken, and last two slides, and it was stented. So the final result, there is reasonably good result, and patient became symptom free. So we have clinical evidence. That is the Orbit-2 trial. 443 patients were tried, and definitely there was primary efficacy endpoints were good, like successful stent delivery. The stenosis was less than 50% like that, and even as well as then MACE events were less when compared to the rotablator Rotaxis. So last slide, that is take-home message. It's a newer device. It's available now. Your device in India, available for calcium modification. It is a new weapon in our armamentarium for treating the calcific coronary disease. It is relatively safe and effective. Some advantages over the rotablation. User-friendly wire, because in my experience, that only one case I have done. User-friendly Viper wire. time consuming because should be done very, very slowly. And it's favorable results with the ORBIT2 trial. Thank you for your patient listening.
Ramakrishnan, actually, this case, did you do imaging on this case?
Pardon, sir?
Imaging was done in this case?
Yeah. Imaging I have done pre. After that I didn't, because of that I didn't go. I had done before the procedure.
So before you have done, after you did not do. So how do you know that the result is good?
Because of hostel, some tortuosity, I tried many times. Then I thought it's...
Only one question. If this case was, if you have no orbital atherectomy, how you would approach this case?
Non-orbital atherectomy, definitely high pressure balloon I could try. Then if it is not available, even sometimes not crossing
No,
balloon,
this case, whether you should have done this case without orbital atherectomy or not.
Definitely, because in this case...
Then how do you do?
No. This case, patient has calcific coronary disease. Even I was showed calcium.
No. My question is clear. If there is no orbital atherectomy, whether you could have done this case or then how you would have done it?
Without orbital atherectomy. Because we are doing for many years now.
Okay, then...
we are doing for many years.
Orbital atherectomy...
But we, just to show that this is the one more device to help to treat calcific coronary disease. That's all. Even with the orbital also, we can do a lot of cases.
No. Second question is, can orbital atherectomy give advantage in any situations?
Pardon?
In any situation, orbital atherectomy is the only choice.
Only choice, definitely.
Only choice of intervention in a calcium, orbital atherectomy. Can you tell one indication?
It's like...
Large vessel is the only vessel where they are actually, even the rotablation, if it is a 4 millimeter or 5 millimeter vessel, deep calcium is there, where actually you can take orbital atherectomy device and do that. In those situations also, there are devices where you can manage with IVL and all. So the orbital atherectomy versus rotablation is not the problem. IVL versus orbital atherectomy will be my choice in this situation. You told the wire. Wire actually, there are auto drive wire which is actually almost equivalent. Now you can take the wire also. Yes. I think Arun Gobi wanted to make a comment telling pro orbital atherectomy.
Just adding to your point, if you want a one lesion where orbital atherectomy will score is an ostial lesion, a pure ostial lesion, IVL will be tricky. An LMC ostial calcium, if you want to debulk, this can go retrograde ablation, and that is one area where this goes over. Large area, you will get a good lumen. It almost does the job of a rotatripsy there.
But 5 mm vessel orbital, you can...
Orbital 5 mm, actually he is telling about a tight ostial calcific LMCA where orbital atherectomy can score. But I have done IVL in those cases. But in this situation, you will be much safer to do that. That's all. I think...
elderly patient relatively little safe when compared to... And learning curve is not that much. Just like when you are compared to rotablator, not much learning curve is required.
What about in ACS patients with the thrombus?
ACS.
Yeah.
Because actually I have done only one, I don't know much experience. I think...
No. It is actually, it has a lot of advantages. Basically, it's a user-friendly device. Anybody can start doing these cases. Rota people have a reluctance to do that. IVL also you can do actually as a device where the IVL crossing of the IVL compared to the orbital atherectomy easy is to cross.
Then presence of thrombus is contraindication for this.
Which one?
Orbital atherectomy.
Definitely. I think with these words we have to wind up the session. Thank you very much, Ramakrishnan and Bijulal, for the wonderful talk.
Thank you, chairpersons and speakers. Yes, for the next session, let's invite the chairpersons, Dr. Bhima Shankar, Dr. Joseph Cardos, Dr. Arun Gopalakrishnan, and Dr. Anand Martanda Pillai.
Good evening, everybody. After a long, intense day, we're eventually at the last session. We have two talks for this. I thought both were actually EP domains, but one seems to be encroached by a pediatric cardiologist. Shall I invite Dr. Edwin to talk on tips and tricks of LA appendage closure?
Thank you, everyone. Good evening. I'll just quickly go through how you select a patient and how you perform a device. I think it is actually a reasonably easy intervention, unlike other interventions. As you all know, atrial fibrillation is one of the commonest arrhythmias. It affects 1 to 2% of the population. And anticoagulation reduces stroke by nearly 60%. Then the question is, why do you need another intervention? 10% of them have contraindication for warfarin, 2% have absolute, and the real world, 40% doesn't receive anticoagulation, and of those who are taking 1 in 5 discontinue in randomized trials. But unlike the previous presentation of PFO, the evidence for an LA appendage is not as strong because there are concerns in the trials and the results are only a non-inferiority trials. The FDA approved the Watchman device for LA appendage in 2014 or 15, and recently, a year back, 2020-21, the amulet from the St. Jude, or now it is Abbott, has been approved for the FDA for the LA appendage. The first study came as Protect AF, in which it was suggested of non-inferiority. The combined endpoint reduced disabling stroke and death was significantly reduced, so it was found to be suitable, good. Prevail, it was, they say, but as 25% were new operators, so overall the increased ischemic stroke was there, but bleeding was less. Based on these two trials, the FDA approved the Watchman device. But what is the real life indications came from the AMBLAT's plug registry, the plug registry, in which the previous major bleeding was a major indication, high bleeding risk and avoidance in the triple therapy. So what are the devices available? The devices are the one and first, not first exactly, the Plato device was the first came in, but it went out of market. The Watchman was the first device which came to the market. It's a self-expandable nitinol cage with 10 peripheral anchors and with a polytetraphthalate fabric cap that covers nearly 50% of the device. Then came the AMBLAT's cardiac plug, which was refined to an amulet recently. It's a nitinol cage, or they call it lobe, for securing the device, and a disc or a plate in front which covers the LA appendage ostium. Its sizes varies from 11 to 30, with the amulet is 34, and the disc should assume a slightly concave shape and cover the entire LA appendage. Amulet was the newer generation. I think now only the amulet is available. Its size up to 34 is there. It's a better anchoring, and it's almost suitable for almost all types of LA appendages. There's a Wavecrest device is not available in India, so I don't go into that. The Lariat is an endocardial and epicardial mode, which is again not done in India. Then came recently the Lambre device from the LifeTech, which is also up to 33 mm sizes there. Only difference is that it has again, instead of a lobe, it has an umbrella and a retention skirt or a cover, which covers the ostium. It has certain lobes which are with the same size of umbrella. It has two covering nitinol covers, so bigger covers. So if it is a different or difficult anatomy, it can enter into one ostium and one lobe and completely occlude the whole ostium. So that's only advantage compared to an amulet. The device selection factors quite vary. The anatomical factors, the prior surgical history, the ability to tolerate anticoagulation and need for the interventions. There are no clear scientific basis to choosing which device from. There are multiple shapes and sizes, but most of the devices doesn't require need to be specific for a specific shape. We can utilize it, or mostly the amulet or the Lambre can be utilized for almost any type of LA appendages. The cardiac CT might be useful for planning a device, and especially with the Watchman, if the length is 17 or more than 30, it is not better used, and in the Lariat obviously can't be used in those with thoracic anomalies. There's a Watchman device with the sizes up to 33 as an amulet sizes. I'll just go through how you do about the cases. There's a case, is a 59-year-old gentleman. He was my colleague's father. He had a stroke, ischemic stroke on oral anticoagulation, so went ahead and did a LA appendage closure. The primary evaluation is like an ASD. It is the proper echo evaluation, the most important thing. You look at the anatomy of the LA appendage, the presence of thrombi and in the process you check for the IAS suitability for the puncture. So the main degrees are like 30 to 45 degrees, 90 degree and 120 degree, 120 to 130 degree. You get the maximum dimensions of the ostium and partly a centimeter or a 10 to 12 millimeter proximal to the ostium, where is the lobe or it has to be lodged. So this is where you measure. The ostium is the point. Just at the level of the circumflex artery, we can make out there's a small dot here, which is the circumflex artery here. You can see. And then proximal to that, there's a circumflex here, and then there's an ostium, and a centimeter proximal to that, you measure the area where the landing zone of the LA appendages. So these are measurements taken both in 30 to 45 degree and then in 90 degrees. So once the measurements are taken, that's the most critical of all, then you can consider for a procedure, and you do a regular transeptal puncture. A postero-inferior septum may be a more suitable, but it doesn't matter if you cannot do that. A regular puncture is done, and then we enter the appendage and do an angiogram with a pigtail catheter. This is a classical description told earlier, but now once we have done enough 10-20 cases, you can just do it. Need not be always like a balloon sizing in an ASD initially. Here they say you take a pigtail through the sheath and do an angiogram. So these are all not required. Once you've done 10-20 cases, you can just go ahead and do like any other case. It's straightforward. So once you assess the LAO cranial view is the usual view done, LAO 20-30, RAO cranial view, RAO 20-30 and a 10-20 cranial. And some cases you can get a LAO cranial views also. But more mandatory ones are the RAO cranial. Once the measurements are made, you can go and deploy. They say you make a small bulb in the in the pulmonary vein. That is the initial recommendation given. Make a small bulb and then come down, slip into the appendage and deploy it. But I think it is not necessary. You can just deploy the regular device. So this is the procedure. You just go in, slip back, and then go into the appendage and deploy the disc. This is one of the first amulets done in the country. It was done probably 5 years, 6 years back. And once you deploy the middle disc and then deploy the covering segment. So after that, the few things we took, there should be a tire shape for the lobe because of the compression. There should be a lobe oriented perpendicular to the LA appendage, LA neck. The disc should be concave. There should be some separation between the lobe and the disc, and there should not be any circumflex compression. This is releasing the device. Once you confirm, you can release. Another example is another lady which had a poor compliance with oral anticoagulation, the chronic atrial fibrillation. He has a ASD also, so just went in and put in an angiogram done. And here it was an ACP, it was a cardiac plug, which was done even prior to the amulet. And then you deploy the device, make sure there is no residual flows, and then in this case I've deployed an ASD device on the way back, and then both have been done in one sitting. There's another indication could be in those patients who have a ASD and a chronic AF. You can do it both in same sitting. You can avoid a natal puncture, septal puncture. This is the last one of the devices, the LifeTech devices, which has been done. Here it is again a pretty large defect, which is measured 19 to 22 mm. The angiogram is done with a pigtail and a sheath in, and this device being deployed. It has an umbrella which attaches to it, so it is probably suitable for almost all types of devices, appendages types, and you check your stability of the device, and then you can release it. This is making sure every time before, make sure there are no para-device leaks that is well attached to the ostium, so that is quite important to avoid any leaks. And then recheck it again, there are no leaks. That is here also is another ASD was there, so ASD was also closed. So to conclude, basically LA appendage, once your indication is clear, then the echo assessment is the most important thing, and the procedure per se, it's not a very difficult one. It's quite simple. Thank you.
Thanks, Dr. Edwin. It was nice talk and nice cases. AHA recommends that you should have minimal 20 cases to run a LA appendage closure program. I guess you're...
yeah, I would have done, not exactly in my institute alone, but then I'm proctoring for the LA appendages, so probably I've done 25 cases. Yeah.
Your skill sets of device closures probably helps.
Yeah, ASD, the assessment is more unlike an ASD, it is more of an echo assessment, more important. Some Western centers say you have to do CT, MRI to assess the LA appendage, which if you can afford to do that, well and good. But I think a good echocardiogram and an angiogram is good enough to proceed with it. Touch wood, I haven't got any MRIs till date, so probably I'm saying on that.
We have time for some questions from the floor. If there no, I have a question. You said PROTECT AF was non-inferior to warfarin. What if today, if you do a study between Novak and...
There is one study, Prague study, in which that's also shown to be non-inferior. This one study is published.
There seems to be no questions. Thanks,
Okay,
Dr.
thank you.
Edwin. We'll call upon Dr. Anish. The next talk is purely in EP domain, at least, on VT storm.
Before we move on to the next topic, I have a small announcement for you. After the session, we are having general body meeting in Crystal Hall at ground floor. So please, everyone gather in the Crystal Hall for the general body meeting. Thank you.
Thank you, Office Bearers ICC, for the opportunity. My topic is management of VT storm. I thought I will present a few cases. The first one is a 64-year-old man. He's post-CABG, has moderate LV dysfunction, and I was called in for recurrent VT and VF. I think it was the third day after CABG. This is the strips from the ECG, ECG rhythm strips. In the background of atrial fibrillation, he was getting recurrent VT. They were shocking him. He was also intubated and ventilated at that time. So if you look at the ECG, you can get, you can see here non-sustained VTs. You can identify these non-sustained VTs. They all begin with a very narrow QRS VPCs. You can regularly see these VPCs in between. Here also you can see that it's all beginning with something like a VPC late on the T wave. And that is setting up the tachycardia. So this is the kind of VF which was initially reported to be able to be ablated. So unfortunately for us, the VF or VT could be suppressed with high dose lignocaine infusion and general anesthesia. So you could even take a 12-lead ECG with a lot of these VPCs alone coming. So with this ECG, you have a morphology of the VPC which is causing the VF or polymorphic VT. And then straight away we decided that maybe we can ablate this and get rid of the VT storm. He was already on amiodarone, lignocaine, and he was getting multiple complications of high dose of these medications. But the patient could not be weaned of GA or IV lignocaine. As soon as you try to reduce the anesthesia and reduce the lignocaine because of the toxicity, he would get recurrent VF. So we took him for emergency VT ablation procedure. During VT ablation, this is the ECG. The same VPCs are reproduced here. This is the same morphology which corresponds to something like a VPC originating from the left posterior fascicular region based on the morphology. So this is what we are looking for during ablation procedure. During the procedure, you get the VPC and then you look for potentials preceding the VPC at the exact point from where probably the VPCs are originating. So this is a point, and the patient was getting incessant VT during the procedure and he was getting repeated shocks. But with sufficient dose of lignocaine, we could maintain him without VF or VT during the procedure, and we quickly mapped the posterior fascicular region, identify the point from where these VPCs are coming. So this is like a focal VPC which is giving rise to VF or VT. So we identified it here. You can see the pre-potentials at the VPC site, ablation, continued ablation, but we have to make sure that we are not ablating any of the bundles. So patient can get bundle branch block like here. If you are ablating this potential, this is with pressure itself, he is developing LBBB. So careful, we had two targets, activation mapping, looking at the VPC site, and also pace mapping, looking for the same VPC morphology as the culprit VPC. And with this, you ablate this site of origin of the VPC and the surrounding scarred myocardium and get rid of the VT. So what was happening initially was recurrent non-sustained VT during the procedure and atrial fibrillation, and this is after ablation. He had received a shock also, and after the final ablation, he was free of any VPC or NSVT. So that is one area where catheter ablation is useful in VT. So as we know, the treatment of electrical storm, the goals are suppress the arrhythmia, identify precipitating triggers, and correct them, establish a treatment strategy to prevent further VT or electrical storms and to prevent mortality. Often the triggering factors, when you look at them, they are only seen in a minority of patients. Most of the patients in practice, when they come with VT storm, do not have a reversible factor like drug toxicity or electrolyte disturbance, new or worsened heart failure, acute ischemia, thyrotoxicity. But even then you have to look at these things because we do come across them in practice. Not in detail about the pharmacological treatment. As you know, the important thing is also the hemodynamic stability. If the VT can be sustained or without shock or anything, then we should try to terminate the VT or VF with pharmacological treatments, and that will also help prevent it from coming back. Ideally, beta blockers, especially propranolol, have been found to decrease the incidence of recurrent VT in a VT storm patient. Amiodarone often is the mainstay of drug. So you ideally have to give IV push of amiodarone 150 milligram. Maybe you will have to take the medicine in your hand and give it within 10 minutes. Then continue the infusion, so that even sometimes you have to continue the infusion beyond the first gram, maybe 2 grams or 3 grams of total amiodarone in the next 1 or 2 days. Lignocaine often is a weak antiarrhythmic drug, but it is useful in certain settings, that is in the setting of active ischemia, and also in the setting like the case which I showed, that is R1T VPCs inducing VF or VT. So in these settings, lignocaine can be useful. Now beyond the drugs, what we can do, deep sedation is very important in ventricular electrical storms. Careful thing is you don't get just benefit with some sedation with fentanyl or midazolam. You have to go for deep sedation, general anesthesia with muscle relaxants, often with propofol or combining propofol with fentanyl. Propofol also has action on the central nervous system to reduce the adrenergic output. Other option is high dose midazolam with fentanyl. There have been studies looking at deep sedation in VT storms. What they have done is, if the antiarrhythmic drugs does not work, they go for deep sedation and general anesthesia. And if the VTs get suppressed within 15 minutes, they will call it a success. They often get success in many patients, and they have a much lower risk of mortality on follow-up. But if you don't get success within the first 15 minutes of deep sedation, you get recurrent VT, then you have to look for other options. The next options which we have to consider are invasive hemodynamic support, neuroaxial modulation, and catheter ablation. So this second case I want to show is a 50-year-old man who got recently admitted with anterior wall MI. This was the initial angiogram picture. Apology for the quality, but he was LAD ostial disease and LAD total with triple vessel disease. And he was taken for angioplasty with IABP support. This was done by Dr. Ramesh. Then last week, this was the initial presenting ECG. Then immediately after the procedure, or along with the procedure, he went into polymorphic VT, shock, pulseless electrical activity, recurrent VF, and then we had to put him on a VA ECMO. Subsequently, after ECMO, he stabilized. This was the initial ECG after ECMO. Then within 2 hours, you get a very narrow QRS complex. So that's one way of preventing VT storm or aborting a cardiac arrest is using mechanical circulatory support. As you know, ECMO is quite effective in that aspect. 50 to 60% of intractable VT or VF will respond to it. The other option which we do not have is tandem heart. The difference is in ECMO you have a membrane oxygenator. In tandem heart you put the cannula in the LA, so you don't need a membrane oxygenator. That most commonly which we can use is Impella device in that setting to unload the ventricle, and if needed complete ablation procedure also in the same sitting. The last case I want to discuss was the VT storm in an ICD patient who came with recurrent ICD shocks, pulmonary edema, neurotoxicity from antiarrhythmic medication, severe airway dysfunction. He was a status post mechanical prosthetic valve. After the initial measures, he continued to have recurrent VT of VF and shock, and we had to suspend the ICD shocks and to give external shock only if the ATP failed and the hemodynamics deteriorated. The next thing which we did was on the day of admission itself, because even after deep sedation and GA, he did not respond. So cervical sympathetic blockade with the bupivacaine injection into the left stellate ganglion region. I will not go into the details because of lack of time, but both stellate ganglion block and thoracic epidural anesthesia have been, as early as from 2000, people have described its use in VT storms, and now it's routinely practiced in many centers when they do not respond to usual measures. The idea is to stop the sympathetic outflow to the heart. Epidural anesthesia is attained, it can be done under fluoroscopy by the anesthetist by puncturing the thoracic intervertebral disc and giving bupivacaine in the epidural space, and that can produce sustained results for more than 48 hours. In this case, after initial mechanical sedation and stellate gangliotomy, we did a 3D mapping and ablation. The patient had a large infraseptal scar which was ablated, and after the ablation, during ablation, he had recurrent VT which could be induced, and we could terminate it with ablation. And finally, as you can see here, he had a lot of VTs and shocks before presentation, marked in red, And this is after ablation, the patient's LV function improved, and before discharge, we even did the defibrillation testing to make sure that the defibrillator ICD is functioning properly. So this was the lot of treated VT-VF episodes before the procedure. This is 2 months after procedure, no recurrence of VT or VF, even though there was some AF recurrence. So, and even after 2 years, he is now VT free. So just to show the combination of mechanical circulatory support, I mean in this case, left sympathetic ganglion blockade and VT ablation. So now, in addition to taking care of triggers for ischemia, medications and deep sedation, then you have to look at mechanical circulatory support. IABP is the common one used, but more effective is ECMO or Impella. Then you have to go for neuroaxial modification and in the end, catheter ablation in most of the cases to prevent future events. Thank you.
Thanks, Anish. That was great. 3 cases exemplifying 3 prongs of approach.
Yeah.
Neuroaxial modulation, one you did ablation, and another mechanical support. We'll still have time for 2-3 questions from the floor. As we get questions, I have a question. How do you time ablation? Oftentimes your colleagues look upon you as though you are the panacea of treatment of VT storm.
How
do you time the ablation time? Like when somebody presents with VT storm?
Yeah, in our setting, because we are not, mechanical circulatory support is not easily available, like Impella and all are not easily available. I usually wait for stabilization under deep general anesthesia and make sure that the patient is stable on sufficient dose of inotropes so that we can do a procedure at least. In the first case, I could finish the procedure in 30 minutes or 1 hour because we are focal ablation. But in other cases, you need the patient to be stable on general anesthesia. So once the patient is stable with small amounts of recurrence of VT, which can be controlled by medications, with or without inotropes to support the BP, I will proceed with ablation. Yeah.
I agree. It's a very heterogeneous population. I think this is a scenario that we can't use one algorithm. Kind of individualize each case and then time or mechanical support or neuromax. Between TE and epidural anesthesia and thing, what do you prefer?
Actually, I don't have experience with thoracic epidural anesthesia. We used to do it in UCLA, but in the last few years, we have done some I think 4 or 5 left stellate ganglion block and ablations. That's all we have done. We should start a program on epidural anesthesia. It's supposed to be more effective. And the effect lasts for 2-3 days. Yeah, you can continue the infusion long term with epidural anesthesia.
Any questions from the floor?
Regarding the use of beta blockers, is it a class effect or does one score over another? Beta blockers and VTs. Is it a class effect or does any particular...
It's a class effect. The idea is to decrease the sympathetic output, but they found that propranolol is much better than... It's a class effect, but propranolol is ideally much better suited for this purpose than a beta-1 selective agent. So when more sympathetic blockade is seen with propranolol.
Would you like to tell, sir, is there any situation where you would say not advise amiodarone in a VT storm?
No, I mean certain situations like if the VT storm is induced by RONT BPCs or in the setting of acute ischemia or severe LV dysfunction where amiodarone infusion may be not contribute and may produce LV dysfunction, lignocaine may become the first choice. Otherwise, amiodarone is the best agent we have at the moment. Yeah, so even in liver failure or enzyme elevation, if the patient is bad, you may have to give IV amiodarone, often the best choice in the situation.
Thanks, Dr. Anish. There's no questions from the floor.
Thank
you. We'll close the session.
Thank you. We are done with all the sessions of day 1 of annual meet by ICC Kerala chapter. Hope you all had a great time.